national level program exclusively for delivering the art of psychiatry. And the importance of this itself lies in because psychiatry is not only biological. It is beyond the medicines. Every year we have this program, and this is the 20th program of Art of Psychiatry, 20th annual program of Art of Psychiatry. This time, this whole program used to be conducted by a particular committee, which is the chairperson, Dr. Desh Sharma, and convener, Dr. Shweta. But since of the COVID situation, so we have the opportunity of having this program in a virtual form, and that gives us a great pleasure also, because now we are joined by the great luminaries as well, because which may not be possible otherwise during the physical conference. This Art of Psychiatry CME is a whole conceptualized by the committee and our president, Dr. G. Prasad Rao. So they have carefully chosen the topics, the faculty, and I'm very, very sure this is going to be a great deliberations, and which will help the people in day-to-day private practice and in delivering of the mental health services across India.
I think Pramod has some connection issues. I would take over. It's my great privilege, and these are the proud moments for Indian Association of Private Psychiatry, because we have with us in this webinar to both inaugurate and give their blessings. First, Professor Helen Herman, our president of World Psychiatric Association, and Professor Afzal Javed from UK. Again, is the president-elect of WPA, is going to lead us henceforth, I suppose, as soon as Helen hands over the reins to Professor Afzal Javed. It is a proud moment for us because both of you are there. And before we start this program, I would respectfully submit to each one of you that just 2 days back, our senior most member of our association, Dr. Jawar, M.K. Jawar, has passed away suddenly with an acute myocardial infarction. He has conceptualized, he has been a national NAV member since the beginning, has always been guiding us. And in his respect, may I just request a minute silence. He's a real towering personality, both in height, both the way leadership. He was the first private psychiatrist from the Uttar Pradesh in Varanasi, and he has led quite a lot of young psychiatrists to show the pathway how to do a private practice. Amar Jawar sir, we lost you, but your memories are always in our heart. And definitely we pray to the Lords that they give strength to Venu Jawar and your entire family, strength to hold themselves. Thank you. I will just have a symbolic lamp lighting just for a minute. And Art of Psychiatry, in these sessions, regularly, year over the year, over the last 20 years, we have been practicing and imparting the education of how to do, how to interview, how to go into the psychotherapies and looking into the art. And in today's session, you are going to have a very unique session in which we are also talking about the uh, the need of the technology of today, the telepsychiatry. So in the symposium, we are going to see that. May I now request Madam Helen Ehrman to give her blessings.
Thank you, Dr. Prasad Rao, my very esteemed colleague, and to all of our dear colleagues, and to my WPA colleague and friend, Afzal Javed, who will be your president in a little over 1 month from now. So I wish him and all of you my blessings and special greetings on the occasion of this gathering, which is a very important one, as you mentioned, because of its place in Indian psychiatry. And I would like to add my condolences to the colleagues and family of Dr. M.R. Janwa. I indeed remember him well as also, and join you in your sense of loss, although, of course, it's much more acute for you and for all of you there. So with you, I look forward very much to the proceedings this evening. I may have to leave you a little early because it's several hours later in Melbourne and I may not last throughout, but I'll stay with you if I may as long as possible. So
Madam,
thank you.
it's really thankful. You can leave as soon as you're, whenever you want to leave, because I know it is late night already in Australia. Now it's my, respectfully, I would request Professor Afzal Javed, a friend of Indian psychiatry and friend of all of us. Why he's friend of the world psychiatry, actually, all over the world, wherever I've seen him in the world congresses, he is being so kindly felicitated by a lot of colleagues around the world. And he happens to be my mentor, I would say, in this public platform because he has mentored me in the nuances of the leadership as I was the Indian Psychiatric Society's president. Professor Afzal Javed, I would request you to give your blessings and your thoughts on the art of psychiatry as well.
Well, good afternoon, Prasad, Pramod, Anu, and all of our other colleagues. It is always a privilege to attend the meeting of Indian Association of Private Psychiatry. And I have been really privileged of attending many of your congresses, and especially the last one, which we were also pleased to have Helen Herman with us in Hyderabad. I think the role of private psychiatry in India is really a role model for many developing countries. And I believe that the maximum number of psychiatrists working in exclusively private area comes from India, and because of are many obstacles, many problems, but they are really doing a great job. And as Professor Helen Herman has mentioned, Indian psychiatry colleagues, and our friends from India have really contributed a lot in national, regional, and international psychiatry. And especially the academic and educational programs that this association and Indian Psychiatric Association have really done a great effort in terms of promoting education, teaching, and training, not only in the regional area, but also contributed significantly in international psychiatry. And WPA has always been privileged of having the expertise and the clinical wisdom of our colleagues from India. Just reflecting on the quality of the program when we attended the Hyderabad meeting, it was exceptionally great. And that really shows that how this particular association takes a pride in choosing the topics which are relevant, which are appropriate, and which are really the topics of the day. And I'm sure this particular topic will also be highlighted in a very, very interesting and effective way. I always say that actually psychiatrists are psychoartists. These are the professionals who have got a lot of skills that unfortunately or fortunately many other medical professionals do not have. And I think this is the art, this is the skill, and this is the wisdom that really makes us very popular despite having so many issues in terms of our etiologies, our diagnosis, and our management strategies. So I hope that, as Prasad has rightly said, that this particular area of digital psychiatry, the new ways of treating and tackling our psychological problems, I'm sure that India will provide a lot of lead. And Professor Helen Herman was very kind when we received the guidelines from Indian Psychiatric Society about telepsychiatry and digital psychiatry. And we were really impressed that how effectively our Indian colleagues have highlighted this particular aspect of new practices in psychiatry. So thank you very much once again. And I look forward listening to the experts, to the friends, and more importantly, having the blessings of Professor Helen Herman. That shows how dear Indian psychiatry and Indian psychiatrist colleagues are to her and to WPA. Thank you very much.
Thank you, sir. Thank you.
May I request Anukant Mittal to just say a few words and on this inaugural function as we go around?
Yeah. Basically, welcome everybody on this relaxed Sunday afternoon to come and make time to log in. The art of psychiatry was conceptualized initially. The lead was Dr. Avdesh Sharma, who mentioned that we call that it's not a science, but it's an art of practice that makes psychiatry unique. And thereon, it was decided that we would have a program which was dedicated not to biological, not to the neurological process, but the art of psychiatry, of how you practice managing to help your patients. And that included developing the art, how to interview a patient, how to assess a patient, how to interact, how to form a rapport with the patient, how to develop a holistic approach to the patient. And to that end, we've had a lot of initiatives by Dr. Avdesh Sharma, who has always been the chair of this section of private psychiatry. We've had talks by spiritual leaders. We've had talks by therapists. We have a lot of sessions, sometimes hands-on workshops in which people have experienced what it is like to do the things of psychiatry that are not about prescribing medications. Again, today's program is exactly a reflection of that vision that Avdesh had. And the mission was to increase people's ability to look beyond medication and look at a broader perspective of the psychological well-being of a patient and work on that broader perspective. Am I right, Avdesh? So,
Absolutely.
So I think we are looking for a feast from what Avdesh has got ready for us. So let us welcome all of you. Thank you again. And thank you especially Dr. Helen and Dr. Afzal. Yes, you have been very supportive to us, and I wish and pray that this support continues in the years to come so that our successors and your successors will carry on this close association and this close participation. Yeah, thank you. Back to you, Pramod.
Thank you, Anukant. Now, may I just request Avdesh Sharma, my dear friend, elder brother, who has conceptualized this program for many years, and this year I thank him for his support along with Sweta Reddy for conceptualizing today's program. And I thank him for the hard work he has put. So I request Avadesh to say a few words before we start the scientific program with Madam Helen Hedman.
Thank you, Prasad, and welcome to Helen and Afzal. I remember that 20 years back when we thought that we should be having a program like this, which was so beautifully put by Anukant, that, you know, we are not teaching enough skills to our medical graduates who pass out of psychiatry to be able to deal with the issues that are brought in by the clients in therapeutic processes. So what started as a retreat, and I remember, Anukant, the beautiful retreat that we had on a cruise actually. We had this retreat for art of psychiatry in a cruise which went from Mumbai, and Anukant had organized it. So the entire process was how to impart these skills to the young graduates. And I must also share here with Helen and Afzal that, you know, IAPP, which is one of the largest bodies in the world of private psychiatrists. And I think it is time that IAPP also becomes much more active with WPA formally. But what has happened in the last 6 months actually has toppled everything, which we would of course talk about today. While on one hand, it has opened up all the therapists in the world. So you could have the best of people from America, from UK, from Australia, and from India. And yet in many ways, there are certain obstacles also that have come in, either because of technology or because of regulation. And going forward, this not only is a big opportunity, but also a possibility for us across the world to be able to join hands and be a part of the teaching and training. And I would, on behalf of IAPP, say to both Helen and Afzal that we would be, as a body, be very willing to take it up at a WPA level to be able to involve other countries also in the future. So we look forward to today's program, and I'm sure that we would be having a feast. Thank you very much.
Pramod, I would request you to give your final comments as we start the first session of Madam Helen Hedman. Okay. May I now request Dr. Sweta Reddy to start the scientific program. Now we have closed the inaugural function at this point of time in this webinar. We had a nice messages from the learned, wise people in this panel,
absolutely,
in this group. So thank you very much, both Helen Hedman and Afzal Javed. And we thank you from bottom of our hearts, but we also request you that you don't spoil your sleep. As your sleeping hours starts, you can go. And Afzal bhai, Abhi, whenever you have, I think you can spend some time with us and then go back. Thank you very much.
A warm good evening to all, and I extend my warm welcome to all of you out there. It's a pleasure to be a host of this CME, the Art of Psychiatry. So under the able guidance of Dr. Prasad Rao and Dr. Avadesh Sharma, it's my pleasure to be a host to you all. And I am sure the CME will help the audience to impart and take the knowledge home and be able to give the psychotherapies with much more confidence and ability. So I invite Dr. Helen Herman, Madam, to give her special address, and I invite Dr. T.P. Sudhakar sir to be the chairperson of this session.
Hello, am I audible?
You are audible.
Okay, thank you. Good evening, everybody. At the outset, I should thank the organizing committee headed by Dr. Avadesh Sharma and Dr. Sweta for giving this opportunity to chair this important session where we have got two international guests. One, the present president of WPA, and of course, the incoming president of WPA. It's really fortunate. And on behalf of IAPP, we thank both of you, sir and madam, to be present in this particular session. And about Dr. Helen Hammond, I mean, everybody knows about her, but for the benefit of some of the youngsters, she is presently the president of World Psychiatric Association. Actually, she is the second woman.
Hello.
And of course, the first Australian to hold this position. She is professor of psychiatry at Oregon. And also, she is the director of WHO Collaborating Center of Mental Health at Melbourne. She is the president of International Association of World Mental Health between 2015 to 2017, and she was the past president of Faswick Rim College of Psychiatrists. In 2013, she got a Victoria Honor Roll of Women, University of Melbourne, which awarded her Doctor of Medical Science. It's called Honoris Causa. In 2017, Queen's Birthday Honours, Madam became an officer of Order of Australia. These are some of her credits. It's a short introduction about Professor Helen Herman. I hand it over to her to give her blessings and the address to start the session. Thank you, Madam.
Well, thank you very much, Dr. Sudhakar, for that very kind introduction, and Dr. Sveta Reddy. And of course, to my dear colleagues, Dr. Avtash Sharma, Dr. Prasad Rao, Dr. Anand Kant, Mittal, and Dr. Parma Kumar. I'm once more delighted to be here, and indeed have very fond memories also of being with you in Hyderabad last year. So I am thank you for the opportunity to speak with you, and I'm in fact going to take the opportunity to discuss the art of psychiatry in a particular way. Thinking about how we work with communities, which is a way of working that I know many of you champion. So I thought it would be interesting to discuss what we've been doing in WPA in this regard and see how this links with your concepts and thinking about the art of psychiatry. Just one moment. I'm trying to advance to see if I can make it work. There we go. So I will speak just for a few minutes now about the work of WPA and the art of psychiatry, thinking about community-oriented practice and rights-based practice, and some links to global mental health. And as in any form of psychiatric practice, particularly that involving the art of psychiatry, we're thinking about partnerships and how to work with others. So I may have shown you this in the past. I'm sure you have seen it, but it's a good reminder for, I think, a valuable touchstone for all of us in psychiatry, that our vision is to live in a world in which people live in conditions that promote mental health and have access to mental health treatment and care that meet professional and ethical standards and integrate public health principles and respect for human rights. And our work in the last 3 years has been focused on expanding the contribution that we in psychiatry make to mental health worldwide, and to reach the people facing adversity and disadvantage. Of course, many, if not most of the people coming to us fill that description. And in addition, there are many others that do not reach us for one reason or another. And are there ways within the bounds of our training and our practice, our interests and propensities to reach out to such people? And the work that we've been doing has been based on collaborating successfully with other organisations and working with psychiatrists like all of you to use their expertise in a whole range of community settings. And I would say that I had the pleasure in Hyderabad to visit the practice of Dr. Prasad Rao and colleagues, which is a wonderful example of successful partnerships organisation and reaching out as well. I thought just in this introductory segment to mention the Lancet Commission on Global Mental Health and Sustainable Development that was published 2 years ago, and the link between mental health and sustainable development and how we can use that in our work, in our advocacy, and recognising the extent to which mental health can be improved through going beyond the health sector, and how our reaching out as psychiatrists and working with partners beyond the health sector is also important. I'm sure that's important in working with community groups as well as working with individuals. That it's possible to deliver mental health care in a whole range of ways that are good for in practice in countries of different sorts. And that in doing that, we keep in mind the rights-based approach to protect people with mental disorders and those who are at risk of poor mental health, and also to promote an environment that promotes mental health for all. So thinking of the adversity and how, whilst we can't solve the ills of the world, we can nonetheless point out the adverse effects that has on mental health. So within WPA, we have a good deal of important work to build on. And I'm picking out one particular aspect in this to be thinking about with our discussions tonight. When we've worked closely with service users or people with lived experience and family carers, recognising that they're essential to our work, whether it's in private practice, in government work, in communitarian work, and that also they have needs that we can be more and more conscious of. And WPA has made recommendations about best practices for working together with service users and carers. And Dr. Afzal Javed was closely involved with this as well. And the basis of that work being in respect, in working with anything relevant to the lives and care of people with mental disorders being developed in collaboration with them and their carers. This is part now of WPA's ethical declarations. And two more of these recommendations, that clinical care as well as education and research and quality improvement also require this collaboration. And we now have a service user and family carer advisory group in WPA. This was established early in the current triennium. And this has been an important activator for us and consulting group, that they've advised and participated in Congress programs and major projects. And our two World congresses of psychiatry that were held in 2018 and 2019, and the virtual World Congress of Psychiatry that will now take place in March 2021. With this will in fact be announced in the next week or so as transitioning from a postponed in-person Congress, recognizing the state of the world, it's now will become a virtual Congress. And we hope, by the way, that once we get well into 2021, there'll be many more chances to meet in person. So much as we appreciate these digital meetings, I think we're all waiting to get back together. And the other program that this group has been very helpful with us in is our program on implementing alternatives to coercion and in our practice. I know that that's very much part of your thinking, part of the art of psychiatry, and something for which the art of psychiatry is central. In fact, I thought hard about having a discussion with you about this tonight, but we'll do that some other time. And how we need to work with resourcing, but also with patterns of practice, much as you're doing, supported by your kind of thinking, to replace coercion with alternatives wherever possible. So what are some other examples to mention of partnerships in this universal health coverage, which is another term for thinking about how do we reach out to all in the community? Well, WPA has developed a curriculum on responding to gender-based violence. So how do we train the trainers, train our colleagues to support people in primary health care, other people in mental health practice, and people in emergency departments, for example, in hospitals, to recognise and respond to the needs for support and protection for women in particular who've been experienced intimate partner violence. We've worked with the World Association of Family Doctors to consider what are the core competencies in mental health for family doctors, and how aware are we as psychiatrists of what it is that family doctors do know, what are their competencies. And the values that Wonka put forward, or the competencies, were considering mental health to be important, to communicate a person-centered approach, to understand how to assess fully a mental health problem, to be able to manage the more straightforward situations, or to know how to work in collaboration and refer to psychiatrists or other specialists, and to engage in reflective practice. It was interesting that many of our own colleagues didn't rate highly the capacity of, or the likely capacity of, primary care doctors or family doctors in reflective practice, although that was probably based on less familiarity with what family doctors tend to or need to do. And as I look at these, it looks very close to what we do in our own practice. And I think is a promising lead to how we reach out to family doctors. Perhaps in training family doctors, there's been really a sense over the last 2 or 3 decades that this doesn't always work. How do we translate the art of psychiatry in a way that's useful and sustainably useful to family doctors? Well, one approach may be, in fact, to train the trainer, to work with our colleagues who are lead family doctors, those with a special interest in mental health. So we worked, for instance, with Professor Christopher Dowrick, who heads a group within the World Association of Family Doctors, a mental health special interest group. So being able to extend the art of psychiatry to these groups would be of great interest to them as well, in the sense that family doctors will listen to their own. So if we train them to be trainers. Another similar set of initiatives is training and supporting nurses and midwives to recognise depression, and particularly in the perinatal period, but that may be in any part of primary health care, of course, and to link the nurses to training and support with mental health professionals to enable them to manage most problems themselves, but to continue to have supervision perhaps, or at least to have access and support from the trainers. And we as mental health professionals, as psychiatrists, to be trained as trainers and in the skills for community-oriented practice, which I might spend another moment shortly to come back to. Very similar principles for working in schools. We can do a great deal by training and supporting teachers to manage disruptive behaviour. So empowering teachers the way we might empower primary care doctors or family doctors, the way we might empower nurses to manage most problems themselves, to continue in contact with and be able to obtain support from the trainers, and that we ourselves be trained and in contact with these groups. And yet again, to be working with young people in safe spaces, if you like, or gathering spaces, whether that be pop-up spaces in social settings, even in the urban slums, there may be places where there are youth workers or social service workers, or even lay workers, where we as psychiatrists and other mental health professionals that we may have trained can make contact with them and enable them to work well and usefully with young people who would otherwise have no way to make connection with mental health care. And this promotes early intervention, especially for the high prevalence conditions like anxiety and depression and substance abuse. So what do we mean by community-oriented mental health work? Well, first, having a sense that using the art of psychiatry, that we as psychiatrists can be effective in settings of adversity, working closely with the people that are active in those, whose primary job is to work in those communities as social service workers, as government workers, or as primary care health workers. Preparing others like these frontline workers to respond to distress and illness and trauma, to give them some training in the principles, and to provide them with support as they do that work, and support for the health workers in primary care and the leaders of response teams in an emergency. And to be using their clinical expertise as needed for the complex conditions, but in the locations where they might be occurring. So this might sound a little familiar because it is in fact adapted from the strategies that are now well used in emergency situations, but that can be adapted to reaching people in urban slums or rural poverty. I know many of you, for instance, reach out in camps or do other work in these settings. So the work in community-oriented practice requires building the relationships that allow that to go on with families and communities. These communities in need have their own complexities, their own character. They're entities, and the families are entities and have their own characteristics. And our role is to strengthen their capacity to respond to the mental health needs of people in adversity. There are so few of us. Of course, we're not doing this work directly. This is how do we amplify our own efforts and do it safely and effectively and be there to provide the added expertise when required. So how do we spread the art of psychiatry, and how well can we do that? So this is more for providing a taste of the thinking that we've been having. But how do we transmit the knowledge, skills, and attitudes in community-oriented or communitarian mental health care? How do we extend the art of psychiatry? Well, if we start at the top left of your screen and think about the role of mental health professionals, the role of psychiatrists. We were all trained in medical management of the sick, which of course is our primary role. But this is nowadays, if we think of the global mental health agenda, if we think of universal health coverage supported by the WHO, all health practitioners, particularly as we think of the pandemic, are being exhorted to extend their vision. And in this case, we're thinking about promoting mental health, advocating for the conditions that allow people to thrive. We're thinking about prevention, about intervening early, reaching out so that we don't see people for the first time when they've been ill for several years. And we are able to prevent much of the psychosocial disability that may have already become part of that person's life. The treatment, of course, of mental illnesses, and also the broad intervention in recovery and rehabilitation championed by many of you. If we think then of psychiatric training, that how can that be broadened to include exposure to community-based interventions? How do we ensure that trainees are given a sense that they can be effective even when there's poverty, even when there's violence, even when there's insecurity of all sorts? That in fact, when we work to relieve a person of their depression or anxiety, that this in turn gives them more power to overcome their own disadvantages and adversity and with their family. And that we need to extend the theoretical base along these lines to cover this expanded role themselves to undertake this work. And research to diversify the evidence base. You've worked hard to extend our vision as psychiatrists beyond medication. And how do we I think there's been an excellent move in the last decade or more to learn more about or undertake more research and broaden the research base in terms of psychotherapy, in terms of social psychiatry agenda. But still, most studies are conducted in middle and high-income populations. So we need to extend its breadth as well as its extent in other ways. Then the system orientation, moving to the bottom of the slide, where, as I've been commenting, we're working in the mental health sector, but looking to reach outside the mental health silo. We're working for mental health being integrated across sectors in moving to work with our colleagues in primary health care and education, in vocation, in housing. People with inadequate housing are much more at risk, as we know, and have much less chance of recovering from mental disorders, and human services. And finally, the culture of our professions. We're used to being regarded as at the top of the pyramid, and hospitals being at the top of the pyramid, and they are in the sense of being the most specialised part of the mental health care pyramid, and they are thereby inherently the group that needs to be accessible finally to those that have the more complicated and difficult conditions, but also that we can look at turning it up the other way, where a lot of the work is going to take place in community self-help, in working with community workers, working with primary health care, and then the mental health professionals, if you like, form the base on the narrow side, that we reach out to each of those groups and support their work, as well as undertake and increase our reach in our own work. So to come to a conclusion, I would say that when we think about the art of psychiatry and the challenge of community-oriented psychiatry, how well do they go together? Our psychiatrists, many of us psychiatrists, many here and many elsewhere, are ready, probably more than some people think. And many seek the opportunity to be engaged with the community, to work in teams, practice teams, social teams, and to engage in systems thinking, that if I work in a school or I work with nurses, how is this going to influence the practice? How will that encourage the access of people who need care to the care they need? And working with the range of partners shown there, with schools, families, working in informal settlements or slums, working with city planning or policy reform, and thereby bringing the skills and the art of psychiatry to those in need in the communities. So thank you. I'll end there, and thank you once more for your attention.
Thank you very much, Professor Helen, madam. They were beautiful and very concise message for Indian psychiatrists. But as you know, India has got an enormous population of nearly 1.38 billions. And we psychiatrists are hardly less than 10,000. Yes. And for a private psychiatrist to carry out all this bulk of work is really difficult, but still we are making some headway because we have changed the very pattern of medical education recently. We are trying to impart training in psychiatry even to the undergraduate level, so that at least they will take away some burden, whatever we had been talking about. And hope we will get some sort of a momentum from them, and probably to a very great extent achieve some of the things which probably WPA had really conceived about. And once again, on behalf of IAPP, I thank you, madam, for remaining awake till late in the evening. And thanks for a very nice message. Thank you, madam.
Well, and thank you, sir. Thank you. Pleasure to be here, and wishing you very well with the program and with your work.
Thank you, madam. Over to the organizers.
Thank you, sir. Thank you for the wonderful comments. Thank you, ma'am, for giving us the highlights and letting us know what should we do in the future. Without much delay, I would like to invite Dr. Debashish Bhattacharya and Dr. Inda Ramasubramanian to take the online platform to be the chairpersons for the next session. I would request them to introduce the session topic and the speaker. Thank you.
Good evening. Dr. Rajesh Nagpal is here?
Yeah.
Oh, welcome, sir. Thank
Uh,
Thank you.
so after a long time,
Sir.
I, distinguished organizers and participants, I am thankful and privileged to chair this session. I am especially thankful to Dr. Abdesh Sharma for inviting me to chair this special session on rational emotive therapy, where the speaker is none other than Dr. Rajesh Nakpal. We know he is one of the most eloquent speaker who can elaborate and comprehensively place any complicated thought or topic to the participants. So I personally also believe that the strength and weakness of our specialty, that is psychiatry, lies in the fact that the branch of our knowledge, unlike other branches of medicine, is deeply connected with other non-medical branches like sociology, philosophy, anthropology, and history of creativity. Accordingly, our treatment surpass the limited practice of medication and almost always incorporate non-drug type of approaches. Again, among the non-drug therapy, we now in contemporary days are not limited to talking cure or psychotherapy or only cognitive therapy. We encompass the non-verbal process of expression and communication, even like art therapy, dance therapy, etc. So today, Dr. Rajesh has rightly chosen the topic, rational emotive therapy, which is actually a connecting link of both the cognitive and emotive process. I hereby welcome Dr. Rajesh for delivering his speech.
Can I say one or two few words before Dr. Rajesh takes over? Dr. Indla here.
Yes, Dr. Indla, just one request. You can also tell that questions should be posted in the chats by everyone.
Okay. So I request Dr. Sweta Reddy to monitor the questions in the chat box now itself, so that we will take up at the end of this session. Of course, about Rajesh Nagpal, I think already Debashis has already said, he is one of the founder members of the IAPP and is one of the main architects of IAPP when we first met in Delhi. And now he is associated with so many psychiatric organizations in India and is one of the very eminent speakers of the Indian psychiatry. And IAPP, he is taking the torch of IAPP ahead in the Indian psychiatric field. So if you think about the rational emotive therapy, anyway, Dr. Rajesh is going to tell. So first, Ellis originally was a psychoanalyst who was the founder of this rational emotive therapy. Later, he was dissatisfied with the psychoanalytical outcomes. So he coined this philosophy, rational therapy. First it was rational therapy, then rational emotive therapy, then it is rational emotive behavior therapy. The main philosophy here is everybody has got some positive and negative beliefs. So the philosophy is to change the negative beliefs which are responsible for the malfunctioning of our day-to-day life. And also another philosophy is that good defense is a good offense. That is another key factor in rational emotive therapy. And another important thing in this is giving a lot of examples during the therapy session. The therapist will give so many practical examples how others will take the same incident if it happens in their lives, and gives a lot of homework. Anyway, we are going to listen to Dr. Rajesh Nagpal, who is going to deliver. And probably many of us are not doing this rational emotive therapy. Probably it has got its own role in our day-to-day practice in so many psychiatric disorders, especially the neurotic problems, personality problems, and other adjustment problems. Now over to Dr. Rajesh.
I thank both the erudite chairpersons who have brought out the highlights of psychotherapy in everyday clinical practice. It is indeed ironic that our younger brethren trained in psychiatry are veering entirely towards biological psychiatry, which of course is extremely important because we deal with drugs and psychopharmacology. There is a revolution on, and it's a brain age. Everything is about neuroimaging and about genetics. But there is a special role for psychotherapy. And I make a case that in the pandemic times, in the intra-COVID times, in the pre-COVID times, and the post-COVID times, psychotherapy, in spite of the biological revolution that we are all witness to, is there to stay. The first question that strikes us is that should a psychiatrist render psychotherapy? It is, of course, not fashionable, and many among us talk about the lack of training. Many of us talk about the number of, or our numbers in the outpatient department, talk about us being badgered with actually patients, and we have no time. But the take of the leaders of psychiatry, like Dr. Avdesh Sharma, Dr. J. Prasad Rao, and others who have given nourishment and fuel to art of psychiatry, is that psychotherapy is food for our soul. We may get familiar with one kind of therapy depending on our training or exposure. Some of us may commit 2 or 3. Evidence-based medicine, evidence-based psychotherapy suggests that it is important to focus on the therapeutic connect. It doesn't matter what kind of therapy you do what you're familiar with. And if we are beginning our journey in psychotherapy, training, learning, and imparting, I suggest we avoid eclectic therapies, at least initially. So I don't suggest a combination of hot seat approach, Gestalt approach, the Rogerian approach, or the Rebt approach and the CT approach, and then the DBT approach. No, that will not do. That does not do in therapy. It has no rationale per se. So when we do psychotherapy or rational therapy, remember, I practice in an urban setting, and I'm only saying what I do. You require to have a certain level of psychological sophistication, which means our ability of the patient to articulate in words what he or she feels, ability to understand at least one language like Hindi or English between the therapist and the patient, affordability. In the Indian context, I might mention that in urban areas, this is what approximately is charged. Sometimes it's about as much as 5,000, 10,000, but I'm saying average is about 3,000 rupees per session, because session takes about 1 hour's time and about 14 sessions are required. A logistic feasibility of attending weekly sessions. Can a person come down and attend, or can he do digitally? You need to explain about booster sessions and flexibility regarding number of sessions. And in COVID times, since there is today a bar on us sitting with a patient for more than 30 minutes or 15 minutes, as some of us say, we are rendering this therapy on the WhatsApp video, on the FaceTime, as Dr. Parma Kumar will talk about on the Zoom or the other mediums. It can be done very easily, actually. So I'm going to plunge straight into therapy because we are all psychiatrists and we are here to learn, and I'm also here to learn. So in the assessment, as a mental professional, I'm looking at recurring themes. I have been guilt-ridden for 3 decades. There is anger from mother. I always thought I was wrong, that I should do more than to make her happy. Mother wanted us for a personal convenience, but also dislike because we were her offshoots. There are a lot of musts and shoulds which we need to focus on, and the recurring themes is talk about irrational thought processes. The Rebt therapist, as Dr. Inla had already rightly pointed out, it was first rational therapy, then rational emotive therapy, and then of course Rebt. And Rebt actually has preceded cognitive therapy of Aaron Beck. Rebt therapists try to assess which thoughts and behaviors create problem for their clients. They might listen for themes that repeat themselves, as I just pointed out some themes. Recurring themes is the answer. Patterns. Identify activating events, rational and irrational beliefs, emotional and behavioral consequences. So the basic conceptual framework of Rebt is an A, B, C technique, and D and E, we'll see that. And this assessment continues in each session and is not limited to the first few sessions. So whatever my patient from Vijayawada, from Guntur, from say Hooghly talks about, I need to pigeonhole it into what is the activating event or the perception of the event, what is the client's belief system, what is the consequence. So obviously we are discussing only negative emotions like anger, distress, despair, etc. And then we do dispute or debate and we have an effect. So essentially, problems need to be assessed in a format which is very easy: activating event, belief system, and consequence. So how does one start the process of psychotherapy? Once you've done the assessment, what you do? You introduce rational emotive therapy, the basic philosophy. The basic philosophy is borrowed from a Stoic philosopher who said that man or woman is not affected by things, but by the view that he or she takes of things. The philosopher was Epictetus, who inspired Albertelli in 1950 in Pittsburgh. We need to have a common language for communication. So I cannot talk about neurotransmitters and about genetic processes, and my client doesn't know anything about it. So I need to have a common language in therapy. And this common language in therapy, shown of all the colloquialism, shown of all the high flow jargon, is basically an A, B, C, D, and E method. I need to give a case example to demonstrate how to use it. So my submission is that once I've done this, I find the person is suitable for therapy. Now I'm going to give a patient an example of how do I use the rational emotive therapy with him or her. So I have taken up an example today about a lady. I practice in Delhi, it's a capital. I practice in a small clinic in a small locality, and my patients are middle class patients. And this lady has been exposed to soap operas and is living in a Punjabi house. I'm Punjabi myself, so no offense there. There is some use of language is a bit of a problem. So the activating event is this, that I need to write it down. I use paper and pen. I write down from the patient. It's 10 o'clock in the morning. It's a duplex house. The husband is standing outside the kitchen door and screaming, "You always delay me. The chapati is going to go hell. I'm leaving." He's going for a job. At that very moment, mother-in-law is descending down the stairs. It's a duplex house, as I said, and is witness to this interaction. And she remarks loudly to her son, of course, for the daughter-in-law to hear, "It's a big mistake marrying her. Young wives nowadays are only fit for shopping or decking themselves. Do you remember your father ever being angry like this? I gave him no opportunity." So these three things which the mother-in-law talks to the son so the daughter-in-law can hear. What happens to the woman when she hears it? She's making chapati, the husband is already shouting at her. So I encourage the patient, the client, to tell me, what is the logical consequence of this? And the first consequence is she says that she'll get angry. Now, when I speak to my client, I usually speak in the vernacular. I don't speak in the English language or the Queen's language. Sometimes English if the patient is highly educated. Otherwise, it's Hindi or Punjabi or some such thing, or even Marathi. So the first emotion is anger. And so consequence is anger. So what's wrong with anger? Obviously, if she gets angry, then she'll step out of the kitchen and she'll say, "Come, I will now teach you what the hell do you mean by actually interfering here," and create a Mahabharata sorts in the house, which happens very frequently in our kind of households. The second emotion which could occur, which might occur, which is not contrary but different, is depression. She suffers from depression that she might rush to a room and swallow a few pills, try to kill herself, and then of course the family would come in and there would be a big family drama happening. So at this point in time, I tell my client that the event which happened, the mother-in-law talking to the son with daughter-in-law hearing, is the activating event. The depression or the anger is not a consequence of the event. The interface which happens between the event and the emotion is the belief system. When I take a McDonald's burger, the interface is the cutlet in between, which decides the taste of the Mac burger. The cutlet here is a belief system. When my partner we have a festival in India called Karwa Chauth, where we look at the moon through a strainer. So depending on the aperture of the moon, depending on aperture of the strainer, I would see the moon in that fashion. Similar sense, between the activating event and the consequence, the belief system rests, and that interface, that strainer decides the consequence. So we as rational behavior therapists are looking at that belief system, that white interface. That is where we focus on. So what is the belief system? We go back to the first emotion. The client said anger. And what is the thought process? So I encourage her to find what thought process. The thought process could be, why does the abusive word not eat in a room and read the Gayatri Mantra? Why does she interfere between me and my husband's personal life? Why does she become, if I'm permitted to speak Hindi, a kebab mein haddi? So it means in English language, she must not interfere. That is the belief system. Now, since the emotion itself is inappropriate, that is that of anger, so logically, this belief system is also irrational. So she must not interfere is the irrational thought process. We'll come to dispute and see how it's irrational in a minute. The second emotion we said is depression. Mother-in-law criticizes me. Husband dissatisfied with me. They are right. I'm a mistake. I am awful. I am bad. So as we understand in psychoanalysis, that if I am ashamed, if I have shame means I'm a mistake. So in depression, it is I am awful. I am bad. सासू माँ मेरी आलोचना करती हैं, पति मेरे से खुश नहीं रहते, मैं ही कसूरवार हूँ, मैं ही दुखों के लिए जिम्मेदार हूँ, मैं ही गलत हूँ. I am awful, I am bad. Pardon for the Hindi, just to get the effect across. Now I shift from the activating event, the belief system, and the consequence to D, the dispute, the debate. Now, for the first time, I'll do all the talking, the blah 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 blah. Next time she'll do the talking, the blah 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 blah. So I'll do the talking now, and I'm now debating with my client, the daughter-in-law of a house, the wife of somebody. The dispute is, the anger, of course, is that, and the belief system, the irrational belief system, she must not interfere. My mother-in-law has no right to come between me and my husband. She has no right to interfere there. She should not be a kebab mein haddi. She must not interfere. Now, my submission to you, my dear client, is that after the passing away of the father, mother is the head of the household. She has a right to see that her son goes to office in time with the stiffen. However, her resorting to speaking with an acidic tongue in the presence of children and servants is uncalled for. When this thought process changes from an irrational to a rational thought process, the inappropriate emotion of anger now becomes annoyance. So after disputing, which I am only attacking the belief system, the thought process, the emotions change by themselves from anger to annoyance. I come back to the second emotion, that of depression, where the daughter-in-law says कि सासू जी मेरी आलोचना करती हैं, पति मुझे कसूरवार समझते हैं, मैं ही बेकार हूँ, I am awful, I am bad. So now I talk to the client. You are a beautiful wife, an obedient daughter-in-law, and a caring mother, all of which is genuine and truth. In psychotherapy, we only speak what is truthful. Today, chapatis got late because of a host of reasons. The geyser did not work, you got up late, you had a pain in the back, etc. A mistake has been made. You are not all wrong. Galti hui hai, aap galt nahi ho. You are not a mistake. A mistake has been made. So when this thought process changes, the depression becomes regret. In Hindi, we call it afsos. When the anger becomes annoyance, the emotion which changes is manageable. And she tells the mother-in-law, Mom, why do you have to insult in front of my children and the servant? You will be separate. I've heard you. You don't need to speak in front of them and insult me and humiliate me. It's not fair. That doesn't create a Mahabharat. When the Bahu feels regretful, she says, Mom, I'm sorry, it won't happen again, and don't keep talking about it. So these are manageable emotions. So my submission is that the initial part, after the assessment, then I will go ahead and teach the client by simply taking an example, like you can take up some example from your own life also, about how do you do an A, B, C, D, E. Then the important part is I explain to the client that emotions are nobody's baby. I cannot change emotions like I can change the switch from off to on. I have no control of my emotions. The activating event, like the pandemic, for example, occurred without my consent. It just happened. The event happened, like a pandemic. What am I left with? A corona anxiety. Whether I am in, except the Atlantic maybe, everybody around the world today is having a corona anxiety. All of us. I myself too. So it is not because of the pandemic, it's because of my perception of the pandemic, the perception that I might have a corona, or I might fall ill, I might be quarantined, I might die, my family might die, etc., etc. The interface is the thought, the belief system that I will have corona, I will suffer corona, I will die, or I will have a problem, etc., or people who I love will die. There's another example I'll give. It's about Mrs. MV suffering a depressive illness and is under treatment. She attempted suicide. She's recovered. The marital situation is taken in term for the worst. The husband and wife has been a problem. Her behavior, the daughter also has become harsher. Just a small nuclear family of husband and wife and a daughter. So we'll go straight on to an example, and the example is about she having tried to commit suicide, and the doctor, the therapist, telling the husband to be caring and warm towards me, and he got irritated. So this generally happens. A woman comes in for a parasuicide, and the doctor, the internist comes and says, essentially she's talking about the fact she's in that emotional disturbance, and she's talking about the family problems. The doctor will always advise the husband to be caring and warm towards her. And he got irritated and he said, "You have troubled me since day one. You're always sick, and now this committing suicide, it's all a weak mind. I don't care one bit." And what is the consequence for this? She begins sobbing, she begins crying. And this is inappropriate because the very fact she begins crying, further it is husband further, and he says, "To hell with you," and there are some problems occurring, and marriage is concerned. Now, what is the wise belief system? He must not get irritated. He should love me. And this is irrational. See, again, the must and the should, that's the emphasis. He has a right to his feelings. He expects his wife to be healthy, and now he's been told that she might commit suicide. So obviously he's very troubled, and he'll speak something. What is the dispute I can do with the wife in question? You must pardon me for my sexist bias. I have had 2 female clients, but of course I do with men also all the time. It's not just females. So dispute is that he has a right to his emotions. He may choose to love me. He may choose not to love me. It might be nice if he loved me enough. It might be nicer if he remained pleasant in spite of the news. That he chose to behave badly is a matter of regret. Now look at the careful choice of words. Look at how it becomes from musts and shoulds to giving the partner space, giving the person a choice to display emotions. What is the effect? Once again, regret. My husband chose to get irritated instead of empathizing with me. Regret will not result in crying or tears. She might remain subdued for a short while, even discuss about his own expectation vis-a-vis her, and the issue might blow over. So, the second example is that of the same mother, the daughter. "You do not care for me. And she is suffering from major depressive disorder, MDD. "I have always looked after you completely in spite of a indifferent father. This is how you treat me after a lifetime of sacrifices." Very common blackmail. All mothers treat, if it's Indian context, their sons to, children to, daughters to. Belief system. "I always thought I was wrong, that I should do more to make her happy." The consequences, so she's feeling helpless, she's guilty and helpless. What is the dispute? The mother's happiness is a state of mind, is dependent on various factors beside her own contribution. She's looking after her mother to the best of ability. It might be nice to serve her mother better, but it's currently all she can do. Mother may choose not to like it. That's daughter's point of view. When a mother decries of her lack of care, concern, love, the daughter might choose to reply that she wished she could do more, but this is the best at the moment. Mother may choose to accept or reject this inadequate effort. Mother again to the daughter, "You do the work assigned. It does not matter if you're tired or hungry. First finish the washing utensils and sweep the floor." Very common during the corona time when we have no servants. Consequences, anger. Inappropriate because it makes you rebel, and the quantum of punishment is higher. Belief system. Mother must not be heartless and uncaring. She should be a loving, caring mother like my friend Ishita's. I hate her. I hate my mother. Dispute. Mother has an irreparable schism with my father. Since we are her children, her writ only runs this far, and she continues to impose unreasonable, harsh tasks on us. It would be nice if mother was kind to us and took into consideration our own needs of love. That this has not come to pass is a matter of regret and unhappiness. Regret. Appropriate emotion which allows her to talk to her mother today of the past without anger clouding our judgment, and harshness is avoided. So my submission to you, my dear friends, is that rational emotive behavior therapy focuses on the present, on the moment. We are not discussing about past events of molestation or things that happened to us in the past in terms of parental problems and the disagreements or violence. Now, after my first session, I request the client to write down 5 examples of either the past or the present which evoke negative emotions. The important aspect here is the client is given a choice to bring whatever food she wants to bring on the table. The psychotherapy is not that of eliciting or evoking things which they don't talk about. She brings on the psychotherapy table what she wants to discuss. So she has a choice to bring stuff she's comfortable with. At my second interview, I don't expect her to bring out deeper conflicts. I expect her to bring out things which happened recently, things which are of some consequence, but not great consequence. So she has the choice to bring whatever she wants to, but at least 5 examples. Try to, at the first, from the word go, try to put the examples in the format of activating event, belief system, and the consequence. Dispute effect I will do with her, but at least get into this format. I give the client the privacy and the permission to camouflage an event. She need not, because since we are in therapy and it's not necessary for us to disclose everything with the therapist, so it's okay to camouflage the event. But so you can discuss, you can talk about Starbucks or cafe or wherever you were, you can change the event, you can change what you are wearing, etc. But at least be brutally honest about your thoughts or perception. That is our only concern. The thought or the perception is the most important. Focus on the primary thought process. What is the primary thought process? We might have 1,000 thoughts a day. So I'm a young girl of about 14. My teacher had detained me in school because the homework wasn't done and she made me work and the school bus left. So I was stuck in Delhi. I was stuck in the Delhi Transport Corporation bus, which is a public transport. I'm wearing a skirt and a shirt, and there are boys who surround me and talk all kinds of lusty and bad things to me. And nobody protects me, nobody saves me, and it's a very difficult event. For 20 minutes, I survive the journey, come home, and I start crying, and I say, my Jiju is good, my father is good, brother is good, all men are bad except that. So from the 7th standard to 12th standard in the co-ed school, I avoid men like plague. I don't want to stand near boys. I hate them. I have to go. I'll go with a group and come back from them. I don't exchange SMSs or social media, nothing with men, only with women. Until I finally go to college. And then I realize, some women can be men, some women can be bad, some men can be bad, some men can be good, some women can be good. That process takes 5 years. All the while, I have all men are bad, that camouflages or that changes my perception about men, and I do not learn to interact with them. So that's a primary thought process I'm looking at. I tell the client that you decide what you want to bring on your plate, what you wish to discuss. If you choose not to discuss areas you're uncomfortable, please don't. This is a journey inside you. This is a Ruhani Safar. This is also an opportunity to become independent and understand yourself. And I'm here to facilitate that journey. I'm here as a mirror. I also give the patient instructions that one doesn't learn overnight to think rationally. Just as I do not learn to use a gun reflexly or a golf stick reflexly, it takes months and months of practice. So you use me like a tissue paper. Feel free to throw me. Nothing is being told to you. You're given choices, rational choices. You can decide what is good and bad for you. This inward journey has a beginning but no end. It will persist and carry on throughout life, with and without. What is the style of a therapist? Forceful. If you want to practice Rebt, be directive in parts. I'm not saying do 1, 2, 3, 4, 5, 6. No. I am saying in some parts be directive, other parts be non-directive. Give the person choices. It's a hands-on therapy. It's in the present, here and now. Rational emotive therapists do not believe a warm relationship between counselee and counselor, like in the Rogerian system, is a necessary or sufficient condition for effective personality change. Rebt therapists fully accept clients as fallible humans without necessarily giving personal warmth. And even when we share personal examples, we describe ourselves as completely fallible. To keep clients from being unduly dependent, Rebt therapists deliberately use hard-headed methods of convincing clients that they had damn well better resort to more self-discipline. So we become forceful, become direct, and sometimes slightly angrier sometimes. as a strategy. So Albert Ellis, as Dr. Already pointed out, was a psychoanalyst by training. His stress thinking assumes that cognitions, emotions, and behaviors interact. Therapy is seen as an educational process. Clients learn to identify and dispute irrational beliefs. It replaces ineffective ways of thinking with effective and rational cognitions, as I give an example of. The most basic premise of Rbts is that almost all human emotions and behaviors are the result of what people think, assume, or believe about themselves, other people, and the world in general. Let's go back to the corona example. When me or my clients suffer from corona anxiety, the first thing that I tell, and all of us tell, I'm nothing unique about it, is now part of the guidelines, that please shut off your TV and do not see it for more than 10 minutes morning, evening. That's all you need to know about the corona. You are not here to treat corona. Don't bother much about it. Just focus on other things in life apart from corona. So, this is a directive approach. We understand that it's a pandemic, everybody was, so we need to develop effective manners. We need to think about changing our thought processes. It's not important to be inundated with knowledge about corona the whole day. We want to make choices of restricting the news of corona to only 10 minutes morning and evening. It's what people believe about situations they face, not the situation themselves, that determines how they feel and behave. Now, the case fatality ratio of the pandemic is 0.1%. But when it affects, that means among severe cases, 1.1%. 1%. When it affects my uncle, my aunt, my friend, I find the corona coming to my house. It's there. I'm there. I'm going to suffer that sore throat and I'm taking the betadine goggles, etc. So it's about what I believe a situation becomes extremely important for me. And this is what I need to change. So in a summary thing, we have the activating event, we have the belief system, we have the consequence, the emotional and behavioral consequence. Dispute or debate is a disputing intervention. Now the new feeling, and of course an effective philosophy. And the philosophy is that men and women are not affected by things, but by the view that he or she takes of things. The ABC model refers to what happens when an activating event leads to an emotional and behavioral consequence. The emotional and behavioral consequences are not caused by the activating event, by the belief system. This vital interface is the belief system. Irrational beliefs occur when the activating event is an unpleasant one. Irrational beliefs can then partly cause difficult emotional and behavioral consequences. I might repeat myself, but therapy is all about repeating, so you might pardon me for that. So that's the activating event. It might be an accident, the belief system, and of course the consequence goes to jail. So you have this issue about the person having a road traffic accident. Therapists often divide activating events into two parts: what happened and what the patient perceived happened. Very common road traffic accident. Typically, the therapists focus only on a few activating events at a time. I focus on 5, you might focus on 6 or 4, your choice. Sometimes these consequences, like for example, being jailed for even 24 hours, become an activating event by themselves. Sometimes it's difficult for the therapist to distinguish between consequences and beliefs. Consequences tend to be feelings such as I feel so stressed out. Feelings cannot be disputed, but beliefs that bring about feelings can. So we need to change our belief system by first finding out what the belief system is, and only then can we alter the consequences. The belief systems are irrational or self-defeating beliefs rather than self-helping beliefs, which is the focus of therapy. So we are only focusing on the negative of the irrational beliefs. Changing irrational beliefs can change the consequences. Ellis' list of common irrational ideas: I absolutely must have sincere love and approval almost all the time from all the significant people in my life. I must be thoroughly competent and adequate in achieving in all respects, or I must have at least have real competence or talent at something important. Otherwise, I'm worthless. People who harm me or do a bad thing are uniformly bad or wicked individuals. I should severely blame, damn, and punish them for their sins and misdeeds. When things do not go the way I would like them to go, life is awful, terrible, horrible, or catastrophic. Unhappiness is caused by external events over which I have almost no control. I have also little ability to control my feelings or rid myself of feelings of depression and hostility. So much later, we divide them into 4 broad categories: demandingness of self, others, and the world; global evaluations of human worth, self or others; awfulizing or catastrophizing, and low frustration tolerance. Here is an example of an emotional episode experienced by a person whose history indicates a biological proneness to low mood and a tendency to misinterpret how he views people. The activating event is what starts things off. Event: friend passed me in the street without acknowledging me. Inference about the event: he's ignoring me, he doesn't like me. Beliefs about the activating event: I could end up without friends forever, and that would be terrible. For me to be happy and feel worthwhile, people must like me. I am unacceptable as a friend, so I must be worthless as a person. Consequences are feeling lonely and depressed, and behavior is avoiding people generally. Albert Ellie is phrased to characterize the behavior of clients who are inflexible and absolute in thinking that they must and shoulds, maintaining that they must not fail or they must have their way. Low frustration tolerance: inability or difficulty in dealing with events or situations that do not go as planned. For example, getting very angry because someone does not do as you ask. Irrational beliefs is unreasonable views or convictions that produce emotional and behavioral problems. Being vulnerable to emotional disturbance for both social and biological reasons is a core view of LS. So we are vulnerable. And that is where it strikes some chord even with the biological aspects of being vulnerable to emotional disturbance for biological reasons. Although individuals desire to be successful and happy, many irrational beliefs interfere with these goals. And disputing a force is a major therapy technique, which I've just talked to you about, and I've shown you how you can dispute it. You can do disputing in 3 parts: detecting. The client and therapist can detect the irrational belief and underlying and the underlying activating events. So you need to focus on the musts and the shoulds. Discrimination. The therapist and client will discriminate between the irrational and rational belief system, as we did just in the example of the daughter-in-law. And accepting that 1 and 2, that is detection and discrimination, knowing that insight doesn't automatically change people, but we need to work hard to affect change. So we just one time won't happen. We need to keep on doing it repeatedly. So developing an effective philosophy in which the irrational beliefs can be replaced by rational beliefs is the product of a successful REBT. So it's all about practice, all about riyaz, which you as a therapist and your client can do together to form a partnership which can last.
Rajesh, time is almost over. Another 2 minutes. Yeah.
3 types of insights develop from that can lead to behavioral change. Acknowledging that disturbances largely come from irrational beliefs and not from the past. Learning how one has reindoctrinated oneself with irrational beliefs from the past. Accepting 1 and 2, knowing that insight does not automatically change, and working hard to affect change. So Ellis believes that when clients have achieved all the 3 types of insights, elegant change takes place. Clients have thus made change and know why they made the changes. That's Albert Ellie, and that is Aaron Beck, the founder of cognitive therapy. As he said, he was a psychoanalyst, we spoke about, and Dr. Inla talked about the timelines also, that first rational therapy. The basic philosophy is it's never the event that happened that make us disturb, but our view of them. It's soft-determinist. Innate character can be changed. It's difficult. It is constructivist. People control their thoughts, and the person assumes responsibility for his behavior. Human motivation to survive and be happy, obtain pleasure, avoid pain. Humans own little of good and evil, being rational about it. Humans are biologically programmed to be both irrational and rational. Self-actualizing and self-defeating can happen together. Ambivalence is the rule. Humans can determine if behavior is bad or good, self or society serving, and self-society defeating. Differences between REBT and CT. REBT focuses on irrational thoughts, CT or cognitive therapy on the problematic thoughts. Therapeutic style is highly directive REBT, persuasive and confrontative. Cognitive therapy focuses on client self-discovery, misconceptions through reflective questioning. Of course, REBT addresses the philosophical core of emotional disturbances as well as cognitions, and CBT is more powerful than CBT in that way. CBT is focused on individuals working on what Albert Ellie calls the inelegant solution. Strengths of REBT is it discourages dependence on counselor. REBT is comprehensive. Beck is the pioneer. It works. We are familiar with the studies. I won't go to that. Weaknesses is REBT does not explain why one clings to the beliefs. Danger of imposing our own philosophy on clients. Doesn't emphasize emotions much. Focuses too much on thoughts. And with that, I thank you, Chairperson, and I thank you, the audience, for a very patient listening and available for questions.
Thank you, Dr. Rajesh.
Yeah.
I think it has been finished almost within the scheduled time, and a vast coverage about this new topic has been done. I think we may spare few minutes for inviting the question from participants.
Sir, I already received some questions. I think I'll ask Rajesh on behalf of the our audience. Yeah. Now, the first question is from Dr. B. Arun Kumar from Nagarkoil in Tamil Nadu. Rajesh, his question is the role of Rebt in Jawans, in army people. Is there any role of Rebt in the army people? He didn't elaborate it. He just asked that. Just if you can answer that.
In my experience, Rebt is very good if you have a common language with the Jawan and if the Jawan is at least 12 standard pass.
Okay. The other question is from Dr. Vishal. Is Rebt is better than CBT? And many people combine both the things. And what is your personal opinion? Rebt and CBT?
My submission, Vishal, is that it's not a question of which is better, what you're more familiar with, what suits your own personality. So if I am a little more didactic approach, Rebt might suit me. If I'm more reflective in approach and my training, I would prefer to have. I don't propose to combine the two things. I think that they are both valuable therapies. They require different kind of framework. I respect and I personally feel we need to be pure in a therapeutic approach. I don't propose eclectic approach. I propose following one kind of therapy. It doesn't matter which suits your individual life and training.
Rajesh, your audio have to be a little more clear.
Okay, sorry.
Before, right?
Sorry.
Yeah. The other question is from Dr. Santosh Gaud. He is asking what is the effectiveness of Rebt in substance use disorders. Is there any role in substance use disorders?
A lot of motivational interviewing techniques use Rebt principles. See, Rebt is very effective in schools for teachers and students. There are some studies for substance abuse also, but primarily to my understanding, since I run 2 rehab centers, is that DBT works much better than Rebt for that. Because DBT is the key for substance abuse and not Rebt. At least this is my perception.
Okay. Another question, Dr. Fani Khan from Hyderabad. His question is, can Rebt be used as an eclectic therapy, especially with the DBT? Especially with the DBT. Can it be
I don't think so. I don't think so. See, DBT is not a pure therapy by itself. It combines many approaches like mindfulness and, of course, parts of cognitive therapy. I don't deny that aspect. We can use parts of it in DBT. And DBT gives you the permission to do so. But combining Rebt with DBT might not work because DBT is a different format altogether. It's tight. DBT tries to solve ambivalences, tries to resolve ambivalences. And this is not about resolving ambivalences. So per se, I think no. The answer to the question is no.
Rajesh, this thing is, do you think that in the Indian setting now, what our clinical psychologists, are they using more Rebt or CBT? What is your personal opinion? I think nowadays we don't hear much about Rebt. Most of the people always say CBT like that. What is your experience?
The reason is, to my mind, because all the evidence is coming for CBT and not for Rebt. But practically, I would submit that both are equally effective. It would depend upon the kind of training that you have. Actually, nothing more than that. I'm not saying one is better than the other. I'm saying that they're equally good. They would suit different styles of the therapist more than anything else.
Okay. Any other questions from anybody else? Dr. Sweta, do you have any more questions? Or Dr. Debashis, you have any more question in your mind, or you want to ask him?
My only comment is that actually among the more approximately 200 types of therapies are emerging throughout the world. So it is very difficult to compare on the basis of evidence, but it is the emerging trend that according to the client and according to the therapist, we usually have to choose the proper therapeutic approach, and we can combine the therapy, one and other therapies, to suit the client. So it is not like that one type of therapy will be applicable to all the patients.
Okay. I think if there are already we are running short of time. I think if there are no more questions, we thank Dr. Rajesh Nagpal for the very comprehensive therapy lecture on one of these being forgotten area in psychiatry. And I thank Dr. Prasad Rao, Dr. Shweta Reddy, Dr. Avadesh, and all our friends for giving me this opportunity. Thank you, one and all.
Thank you, sir.
Thank you for
Nice work, Rajesh.
Thank you, Dr. Rajesh Nagpal and the chairpersons for conducting the session very well. I would like to invite Dr. Tufan Pati and Dr. Shashi Rai to on this digital platform to conduct the next session.
Hello, am I audible?
Yes, ma'am.
We are here. We are here.
So good evening, everyone. It's a privilege to be chairing this session. And I thank Dr. Prasad Rao, sir, Dr. Adhish, sir, and Dr. Shweta for having given me this opportunity. This session is on mindfulness in the context of therapy. Basically, mindfulness is paying attention to the present moment. It's the conscious awareness of the present. And basically, it involves intention, attention, and attitude. It has lots of benefits in our day-to-day life. Proper mindfulness, if practiced, it improves our focus, our concentration, and reduces stress, improves our mental and physical well-being. So you'll hear a lot on this by Dr. MP Sharma. I request Dr. Tufan Pati to introduce the speaker and then start the session. Thank you.
Thank you. Thank you very much, Dr. Sasirai, for asking me to introduce. First of all, I profusely thank Dr. G. Prasad Rao, Dr. Avdesh Sharma, my dear friends, for inviting me to introduce the speaker of the evening, speaker of this program, Professor Mahendra Prasad Sharma. Professor Mahendra Prasad Sharma, head of the Behavioral Medicine Unit of Midwives. Am I audible?
Yes, sir.
Yeah. He is the head of the Behavioral Unit of Midwives, and his expertise as well as his unit's expertise is in third generation behavior therapies. And one of the third generation behavior therapies is mindfulness-based CBT. And his basic interest in meditation or Vipassana meditation was evident when he published the first paper, first study on use of mindfulness and Vipassana meditation in mental health. He has 80 publications and 200 presentations to his credit, and some awards. Let me read it. He has got Professor H.N. Murthy Oration Special Honor Award in 2018 Conference of ISCP, a member of Expert Committee of the RCI, and in the Golden Jubilee year, 50 clinical psychologists were given urges and recognized as icon clinical psychologists, and he was one of them. Dr. Sharma, I have reduced your biodata, which was very large with me. I think that's okay. And with this, I will make a small quote. The quote is from Tichakna, who is a Jain Buddhist philosopher. The thing is that present moment is the only moment we have. The present moment is the only moment we have, and it is to get to all other moments. I think this is relevant to this, I'm sure. With this, I invite Professor Sharma. The stage is yours. Dr. Sharma, please.
Thank you very much, sir, for introducing respected chairpersons, office bearers of the IAPP, distinguished guests, and dear participants. First of all, I thank organizers of this wonderful webinar on the art of psychiatry, in which we are talking. We have just had a wonderful talk on the Rbt, and I am going to share with you one of the topic which is very dear to my heart. So here I'm just putting the Okay, I hope it is. You are able to view it. May I proceed?
Possibly you need to make it smaller.
Yes.
Oh,
the slide is
okay.
getting cut.
Little bit smaller.
Is it okay or still it is?
It's not visible.
Is it visible now?
It's visible.
It's visible. You can go ahead, sir.
You can go ahead.
Dr. Sharma, you can reduce the size just below where that icon is for slideshow. Below that, there is a slider on which you can reduce the size. You can reduce it.
That's right. That's
now
right.
when you put it on, it will be coming.
So now it is 21.
Yeah, you just make it slideshow.
How it is now?
Better.
Still I reduce them.
Yeah.
We'll try this.
It is minimum.
Okay.
Yeah.
Okay, I think we can go ahead.
I think we can go ahead.
Okay. So as we all know that behavior therapy movement, which have come, the field of behavior therapy tradition in the response to the classical psychoanalysis and behavior theory approaches were emerged as a approach which committed to the development of well-tested, rigorous and applied therapeutic procedures. And we saw the first and second generation of intervention. First generation behavior therapy in the field of behavior therapy were based on learning theories, particularly the classical conditioning and the operant conditioning. And later on, in the 60s, with the Albert Ellis and Aaron Beck, we saw the introduction of cognitive therapies. And then we all know today the field of the CBTs. And these are the therapies which are a wide range of therapies and which are from clinical behavioral analysis to the various type of cognitive therapies. In last 3 decades, we have witnessed emergence of new approaches which are dialectical in nature. They have spiritual component, relationship component, and particularly the mindfulness component. These cognitively rationalized approaches, particularly those emphasize the role of metacognitions, are questioning the primacy of change in the cognitive content. What does it mean? It means that in Rebt or in cognitive therapy and other cognitive therapies, basically there is emphasis or the aim of the therapies is to bring about cognitive content by various methods which are being used for the cognitive restructuring. But these approaches are saying that it is not necessary. What is necessary is to observe them and not to interfere with them, not to get involved with them. So the mindful-based interventions represent such approach. Training in mindfulness through different variants of mindfulness meditation constitute key component of these interventions. And let us come to understand what is the mindfulness. What we have to understand that the mindfulness comes from the Buddhist tradition. However, this technique has been there in ancient scriptures, Indian scriptures. The Gautama Buddha basically rediscovered this technique, what we know as Vipassana. And basically, in the meditative tradition, the meditation has been utilized as a method for the self-discovery, to know oneself. So let us understand meditation and the mindfulness meditation, and then the mindfulness in present context and as a mental health professional. So as far as meditation is concerned, probably it is one of the oldest relaxation technique. As you all aware, that relaxation training is the key component of behavior therapy intervention. It is something like paracetamol or aspirin in the medicine. So in the last 4 decades, there has been a very sharp interest in the study of meditation and its application in treating individuals with mental health problem as well as physical health problems. And meditation, broadly, it can be classified into 2 major categories. They are concentrative kind of meditation and the mindfulness meditation. And there are more than 100 methods of meditation. And whether it is concentrative kind of meditation, like, for example, Tratak, or reciting a mantra, focusing one's attention on a particular image, or the mindfulness meditation. The purpose of all these meditation has been cultivating witnessing. What has been termed as Sakshi Bhava in Indian tradition, or the awareness of the mindfulness, is the aim of all these meditative techniques. So when one is mindful, one is meditative. Coming to the mindfulness meditation involves expansion of the attention or awareness to become the aware of ongoing sensations, feelings, images, thoughts, sounds, smells, and so forth, without becoming involved in thinking about that. So basically being aware of what is happening within oneself and around oneself without getting involved, and having a non-analytical let-go attitude. So the mindfulness meditation can be compared with a wide angle lens, be aware of entire field, 360 degree one can call it. Mindfulness meditation is not an effort against the mind. Basically, there are misconceptions that mind is the enemy and mind is to be tamed and it should be controlled. So basically, it is not effort against the mind, it is way of understanding the mind that we have to, and it is a effortless effort. What is an effortless effort? It is something like every day in the night when we go to bed to go into sleep, we don't make effort. Only we just prepare ourselves and just lie down. We don't make any effort. And if you try to make more effort to sleep, as in patients with insomnia, we have observed they are not able to relax, they become more wakeful and sleep does not come. And when one understands the working of the mind, a great awareness arises. And this awareness is not of the mind. In the consciousness studies and tradition, it has been said that wisdom which arises, or that awareness which arises of the consciousness, prajna parimita, the wisdom beyond the wisdom. It is non-doing. I mean, that is, though we, in ordinary language, we say that, what are you doing? I am meditating. No, it is not doing. Actually, meditation is process of moving in the mode of non-doing. That is, I mean, that is going into a state of being. And then it is not control, it is not repression. Of course, these are the problem in the part of the practice because of our conditioning as being a human being. So the mindfulness meditation can be equal to attention without tension. That is, when you are attentive and you don't have tension. So when one is mindful, one is meditative. It is example of the effortless effort, just this picture described by itself, how the ants do. So coming to the standard definition of mindfulness, mindfulness is paying attention in a particular way on purpose, which means the attention is a special, in a special way. I mean, that is the to observe in a special way. That is the word meaning of vipassana also. And so in the same way, the on a particular way, on purpose, I mean, that is, it is willfully and in the present moment and non-judgmentally. When we talk about the present moment, it doesn't mean that one cannot have thoughts, feelings about past or the future, but one have to be aware that is right now I'm experiencing thoughts or emotion related with past or the future. And the non-judgmentalness, as you all know, it is one of the important therapist characters also. But here what we mean, that is being, because we as a human being, we are conditioned to judge. Our language, our whole socialization process is like that. Therefore, we will bound to judge. So even being non-judgmental for judging. So whenever one become aware that one has judged something, not to become upset about that one. The second definition is elaboration on that one is mindfulness is a kind of non-elaborative, non-judgmental, present-centered awareness in which each thought, feeling or sensation that arise in the attentional field is acknowledged and accepted as it is. What are the components of mindfulness? Focus on the present moment. I have just explained about that. Being fully present, mean that is full alertness with a totality. And the third one is openness to the experience, curiosity. Mean that is like one have to be curious like child. What next thought I'm going to experience? What image I may get there? Because we don't know in the next moment what thought is going to appear in my experiential field. Non-judgmental attitude, about which I have just said few words. Then acceptance of the thing as they are. Acceptance is the one of the key component of the mindfulness. Accepting the things as they are and without changing. And that is the way to the reality, experience of the reality. And next one is connectedness or connection with the self. So the mindfulness is basically understanding oneself, connecting to oneself, and with a non-attachment, or what we will learn later on the decentering or diffusion. It is also being termed as anasakti in Indian philosophical thoughts. Peace and equanimity, that is staying in the middle. Buddha's path is also referred to as middle path, the Mijjhima Nikaya. And last but not the least, the compassion. Mindful compassion is the one of the important component, and once you become compassionate towards yourself, only then you can have compassion towards others. So these are the major components of the mindfulness. And what are the basic principles? Coming to that, to observe the thought and feeling as mental events. As there are physical events like breathing, heartbeat, or eyes are blinking. So all that which is happening within ourselves, thoughts and feelings, they are to be viewed as, observed as mental events which are coming and going, and not to become absorbed in their content. And seeing them in a non-judgmental way, without judging, without evaluating or attempting to change or avoid them. Neither saying that it is good thought, nor saying that it is a bad thought, it is bad feeling, good feeling. Whatever is. And with a sense of acceptance. Here is the example to realize that I'm having the thought that I'm a bad person, rather than concluding that I'm a bad person. Getting a thought such as I am a bad person is just a thought. By getting a thought, one doesn't become a bad person. But if you identify with this thought, if you fuse with this thought, then the problem arises. That is what the mindfulness says. The acceptance of constantly changing experience of the present moment. There is a concept of impermanence. Nothing is permanent in this world except the change. So every moment the change is occurring, and this change is to be experienced, which may occur within, which is occurring within ourselves and around ourselves. So therefore, this concept of impermanence is also being used for the negative emotion, negative thoughts, making the person understand that things are not permanent. This too will pass, and developing this understanding more and deeper and deeper. As far as practice of mindfulness is concerned, there is a formal practice and there are the informal practice. Formal practice involves different variant of mindfulness meditation. Most common are the sitting meditation, body scan meditation. Apart from them are the breathing awareness, mindfulness of sound. So such mindfulness of walking, if willfully it is done. And the informal practice involves application in day-to-day activities. So with some of the pictures, and I would like to explain the key proposition of mindfulness. Most sensation, thoughts, and emotion fluctuate. So the analogy or the metaphor is of the that our thoughts and emotions are like waves in the sea, and we have to observe them like that. Then this is the another metaphor of the passenger train. So we make our clients, our patients, to think yourself. We tell them to think that they are a passenger waiting for a train, and mind is like a busy station, and thoughts are and feelings are like train passing through. So there is no point in trying to stop and climb aboard a train that is passing by. Just be bystander, watch your thoughts pass through. There is no point in climbing aboard to be whisked away by the wrong place. So this helps patient understand the concept of mindfulness. Then another metaphor of the flying bird, which is flying on the lake, and when the bird is on the flying above the lake, then its reflection is there on the surface of the water, but the lake does not try to hold it. Or one can use the metaphor of the mirror, because whatever comes, it reflects. So in the same way, our mind required to reflect whatever is happening within ourselves. Then cloud metaphor, that is the thoughts and emotions are like cloud, and as we don't have any control over the clouds because they are part of the Earth's self-regulating weather system, so there is no need to control. Rather, try to treat them as a passing thoughts and emotion as a passing clouds, and allow them to occupy their own space and time in the knowledge. And clouds are momentary. The sky is permanent. So is our inner sky. That is what we try to make understand our clients. Emotion is floating leaf in the lake, or is surfing. It is a concept which is being used in the substance abuse, where craving is the major problem, and in which like to observe the craving and not allowing it to overpower you. Like as people have, you see wave surfing, in the same way you use this concept. Then let go attitude. Be light and relax. Don't be serious. Be playful. That is, seriousness is the disease. So what we teach our client is to relax, so that by having the let go attitude, that is, one become lighter and one feel better. So on the application part, like the what we call informal practice of mindfulness, the activity, any activity plus awareness is equal to the mindfulness. So it is not limited to the formal practice, but the formal practice is necessary to cultivate the mindfulness, and then you can apply into day-to-day activities. For example, eating food. Finish each mouthful before reaching for the another. Be aware of every bite, taste how the taste is, how you're feeling, smell, everything. So with the awareness and enjoying your food with the awareness. Then mindful walking, like being observing when you are walking, listening whatever is happening around, smelling, feeling, notice, sense, appreciate, experience, admire. So that is mindful walking. Mindful speech, think before you speak. So because word may hurt others. So mindful speech. So in the similar way, one can apply to any activity like mindful bathing, mindful singing, everything. Then opposite to the mindfulness is mindlessness, like forgetting somebody's name right now after being introduced. Sometime you walk into a room or your study room and you wonder for what purpose you have come here. Or you keep on eating even when you are not hungry, or people become very upset because they get stuck in traffic jam. They go through a lot of thinking and emotions, because the traffic will clear, then it will clear. So that is also mindlessness. And like walking or driving for hour or so, what has passed through. So what mindfulness is not? Mindfulness is not trying to relax. It also part of the relaxation training, but in real producing or inducing the relaxation is not the aim. It happens, that is a different thing. Then mindfulness is not a religion. Whatever we are utilizing or applying are the clinical models. We are not following what is being followed in the Buddhist monasteries or other such monasteries. So our aim is not nirvana, moksha, kaivalyam. Our aim is to utilize this particular method to help the individual to understand their cognitive and emotional processes. Mindfulness is not difficult. At the prima facie, it appears easy, but it is difficult and require regular practice and understanding of it, and developing like non-judgmentalness, non-elaborative, and attitude and let-go attitude. Mindfulness is not emptying the mind of thoughts. Generally, people say the meditation is like thoughtlessness. That happens, but that is the outcome, you see. You cannot induce it. So one have to keep on observing once mental events, and a point come when there would be no thought. Mindfulness is not escape from the pain, that is accepting the pain and suffering. As far as evolution of mindfulness as a therapeutic approach is concerned, it started with the basic research on meditation, including mindfulness meditation, especially in the 1960s, the initial studies on EEG studies on Buddhist monk, then application of in chronic pain by Kabat-Zinn. Initially, then in 1985, in American Journal of Psychiatry, one study was published in which...
Just a minute, Dr. Sharma. Just a minute.
Yes.
See, it is time as told by the organizers, but in view of the glitches in the beginning, I request you to complete it soon, maybe within 3 minutes.
In 5 minutes or so, sir? How much time I have?
Your time is over. You can take 3 to 5 minutes finish it. So we will adjust discussion accordingly.
Okay. So with the integration of psychotherapy, application in anxiety disorders, and then the MBCT, which came basically for prevention of a depressive episode in recurrent depressive disorder. So mindfulness in the context of therapy, when we see it is a trans-diagnostic in nature, relevant in psychological disorder and physical condition, because people with physical conditions also have a lot of mental health issues. Anxiety and depression are common. Then it has been incorporated in many therapeutic interventions. Like these are the MBSR, MBCT, mindfulness integrated, CBT, Rebt, dialectical behavior therapy, acceptance and commitment therapy, metacognitive therapy, and emotional regulation therapy. So the aim is shift from object mode to metacognitive mode, interrupt perseverative negative processing. The third one, to enhance executive control over the allocation of attention, prevent the thought from influencing self-concept. These are the 4 mechanisms. Acceptance, I have spoken already. Then exposure, that is basically acceptance ultimately leads for the psychological flexibility and helps the individual to see oneself in the context. Then prolonged observation of thoughts and emotion serves as an exposure, like in exposure-based technique in behavior therapy, and encourage the extinction of the negative emotional process. Experiential avoidance, which refers to avoidance of experiencing negative emotion. So the mindfulness helps and encourage people to experience negative emotions, and which helps in uh, emotional reprocessing of painful or traumatic experiences. So this is the cognitive change. The cognitive change which occurs in the mindfulness through the mindfulness approach is the metacognitive in nature, and non-judgmental observation of the thoughts and feelings develop understanding in the person that phenomena are not the reflection of reality. I mean, that is the thoughts are just thoughts. Thoughts are not the fact. That is the what we call that the metacognitive awareness. I mean, that is, I'm thinking, I'm seeing, I'm wondering, I'm noticing, I'm feeling. Then cognitive change, I mean, that is which occur is through the decentering and defocusing from the thought and emotional processes, and it enhances the cognitive flexibility. It helps in the self-management in day-to-day activities, facing with the stress. Then relaxation, as already have said, is not the aim of mindfulness, but it produces relaxation response, which is opposite to stress response. Then there are many studies. There is a rich literature on the mindfulness and its efficacy, its application in psychological and psychological and disorders, as well as in physical condition. Here I'm referring a latest article in Acta Psychiatrica. A systematic review has published recently in 2020 in probably the latest issue. They have conducted 83 published studies from 1975 to 2019. The occurrence of meditation adverse events during or after meditation practice is not uncommon and may occur in individuals with no previous history of mental health. Meditation practices are associated with report of adverse events, particularly anxiety and depression. What has also referred earlier as the relaxation-induced anxiety. The overall prevalence of meditation adverse event is 8.3%, is similar to those reported for psychotherapy practice in general. There is no standard assessment of adverse events in the reviewed literature. Further research should focus on how meditation outcomes are affected by context and individual differences, including appraisal of meditation experiences. So I end with the prerequisite. The training is required, and without training, it will be difficulty in applying in the therapeutic situation. Standard instructions are to be utilized. For the practice, place, time, and duration are to be decided. That helps the individuals. So, in conclusion, research has shown that majority of people who went through mindfulness-based treatment program report lasting reduction in both physical and psychological symptoms. Their attitude and behavior undergo deep positive changes that are rooted in a less conflicted perception of self, others, and the world. This result increase ability to cope effectively with both short-term and long-term stressful situation. It enhances physical, psychological, and spiritual well-being. Therefore, mindfulness, meditation, and therapeutic program based upon its basic assumption and practices can be used effectively in the treatment of wide range of mental and physical health problems. Thank you, sir.
Thank you, sir, for your elaborate talk. And we have 3 questions for you. The first is, does mindfulness have an advantage of meditation, which most gurus advocate to the general public?
Can you repeat?
Yeah, does mindfulness have any advantage over meditation? Which
Over
general gurus advocate to the public.
No, medicines have their own role, you see.
No, medicine, meditation. Does meditation have any advantage over mindfulness? Vice versa.
Sorry, madam, I didn't get your question. Can you just repeat
The question
slowly?
is,
Sir, would you please unshare the screen? This screen is, PPT is not needed. It would be better. You can see you.
is mindfulness better than meditation?
Meditation.
Meditation.
Medicine?
Meditation.
Dr. Rai, yes, Dr. Rai asking whether it is better, compare it to the medications which is given for different psychological conditions.
No, I mean that is as far as pharmacological treatment or the medicines are
Sir,
concerned.
not meditation. It is meditation. Meditation.
Meditation.
Yes.
Sir, the question is, does mindfulness have any advantage over meditation, which most gurus advocate to the general public? It's meditation.
You see, the purpose of the meditation, I mean that is to cultivate the mindfulness. So naturally, I mean that is what is like for the general public. There are, as I said earlier, there are different kind of meditation technique, and they are certainly useful, and people do get benefited. But what we are following are the clinical models, and which are again along with the other therapeutic methods. So because these methods which we are using, they are evidence based. What are being suggested by the spiritual leaders or gurus, they are effective, but whether there is a scientific evidence for that one, because there are some techniques for which there are evidence, but for many it is not, and there are different kind of meditative techniques.
So the next question is role of mindfulness in recurrent depression. Recurrent depression.
Yes, recurrent depression. Okay.
Yes, sir.
So this MBCT, which was a program developed, which is the blending of traditional cognitive therapy plus the mindfulness, and it was basically used for the people who have at least 2 episodes of depression earlier, and the purpose of this was as a psychological prophylactic. I mean that is, and what they have observed, I mean that is when with the patients with recurrent depression, when they have gone through this MBCT program, they have learned to identify any person who have a relapse, so is about or impending relapse is there. So in the beginning, it will start with the automatic negative thoughts about the self, others, and the world, and the person would able to recognize them. Either he himself may overcome them by applying the mindfulness, or if he finds it difficult, he can contact his psychiatrist or his psychotherapist, who would help them in the very beginning of the initial stage, and will in that way help him to abort the depressive episode.
Thank you.
Okay.
Now I request Tufan to his concluding remarks.
No, the concluding remarks is that we are already more than 15 minutes into the next program. Dr. Afzal is waiting. But we had an elaborate discussion, a nice deliberation by Dr. Sharma. Thank you, Dr. Sharma. And we are enlightened. We are enlightened by meditation. Thank you. Over to the
Okay,
organizers.
thank you very much. I thank you, the organizers, again to give me this opportunity. Thank you all listening patiently.
Thank you, sir, for the wonderful discussion, and thank you, chairpersons, for conducting the session within the time. And we go ahead to the much awaited panel discussion. The panel discussion, to start with, I should say that as a moderator, I am Dr. Shweta from Hyderabad. And to introduce, disasters and pandemics pose a unique challenge to provide proper healthcare. Though the telemedicine will not solve all the issues, but it will definitely allow the practitioners to evaluate and manage their patients remotely and effectively. However, the concern is that due to lack of clear guidelines, and which has created ambiguity amongst us, so that is the reason why we had kept this panel discussion to discuss and learn from the experts how to conduct psychotherapy on a digital platform and resolve our issues. It is my great pleasure to introduce the panelists to you all. Dr. Avdesh Sharma is a consultant well-being psychiatrist with over 35 years of clinical practice in Delhi, and currently is the chair of WPS section of spirituality and psychiatry, and also chairs the spirituality and mental health task force of the IPS. He has been the international lead on public education for the World Psychiatric Association. I welcome you, sir.
Thank you, Shweta.
The next panelist is Dr. Anukant Mittal. He is a professor and head Department of Psychiatry, Rajiv Gandhi Medical College, Mumbai, and Director of Behavioral and Neuroscience Academy of India. I welcome you, sir. Good to have you here. Dr. Mittal, sir?
He seems to be frozen. Okay.
Okay.
Yeah, sorry, was on mute.
You.
Yeah. Thank you very much, Shweta, for the kind words.
Thank you. The next panelist to introduce is our very own Dr. Parma Kumar, sir. He is running a comprehensive psychiatric clinic named DPC at Chandigarh, and he is the Honorary General Secretary of IAPP and also the Vice President of Indian Association of Biological Psychiatry. He is honored with International Fellowship of American Psychiatric Association and has been elected as its ambassador by APA. We are lucky to have you, sir, in this panel.
Thank you, Shweta. And
yes, please go ahead.
IPL season is about to pick up, and it appears as if I am with the two opening batsmen with the great records of 30 and beyond. I'm like an extra man carrying bottles for them. That's thank you. Let's do the justice to the panel discussion.
Yes, sir. And last but not the least, the young and energetic Dr. Avinash D'Souza. He is a consultant psychiatrist based in Mumbai, Honorary Secretary, Indian Association of Biological Psychiatry. I welcome you here, sir.
Thank you so much.
Thank you. So, so the panel discussion goes like I'll be posing you questions, much awaited. So you will have time to answer them, sir. So we have time till 8. So I'll start my first question for Dr. Avdesh Sharma. What are the opportunities, sir?
I would request, because there are 4 panelists, we can go till 8:15 if everyone agrees.
Okay. As you say. Yes, sir. So the first question to Dr. Avdesh Sharma, sir, is what are the opportunities and obstacles in taking psychotherapy on an online platform?
Thank you. Yes, it is going to be like a T20, Pramod, with the time that we have and 4 of us.
Yes.
So welcome from 3D to 2D or no D, which means that we are shifting from what we were used to in physical form to now just the virtual form. And sometimes when we are on the phone, then we have no form. and the 5 senses to 2 senses, or 1 senses like on the telephone. Now, the challenges that it has thrown us, let me just briefly talk about that. We don't know who's providing what. The regulation which is there for psychiatrists as far as psychiatric practice is concerned may not be there for so-called therapists. We don't know what their background is, or those who are providing counseling, or those who are providing healing. And many of them are providing all kinds of services for all disorders, including psychiatric ones. The second is the second challenges of technology. Some people are very savvy with it, as far as the providers and patients are concerned. But those who are not, then they are going to be left out of it. It's like the same as the education divide. Earlier on, at least people would be able to go and meet people physically. Now, if you're not able to, but the silver lining there is that telephone is much less used technology. It is available. We have been using it for a long period of time. And I think in telemedicine, although the issue of non-verbal cues, etc., may be missed out, but that's something which we can use in the interiors. The obstacle again is that I, as a practitioner, unless I have the skills, and this is where IAPP started the art of psychiatry, to teach skills to psychiatrists. Now you have to teach a different kind of a skill to provide art of psychiatry through technology, because that's not taught again as far as the medical colleges are concerned. But the opportunity that is there is that we can learn different skills. We have time now to learn new skills. I can learn RET, I can learn CBT, I can learn mindfulness and apply it to my practitioners. The other obstacle that is there is about economics. Large number of people, when they were seeing a doctor, now when you get a prescription, maybe it's easier for some elite customers who are able to understand the concept, it's easier. But we have number of sessions unless they are committed to it right from the beginning. And to add to what Rajesh was talking, or Dr. Sharma was talking, 2 or 3 sessions are taken by a client to understand what you are going to be providing, and for me to understand what kind of therapy I need to be giving to this person, by which time the person may start becoming restless. And lastly, because we are going fast, but I think the opportunity that is there in future is for us in IAPP to say that we are there, we are on the ground, we can handle in a district, let's say, those who are working with the government sector, or those who are working in the community like Helen and Afzal were saying, and we can be the nodal person to be able to handle all kinds of mental health services, including the government-run programs. And that's something that you can pitch for in the coming years. Anukant, you have a great possibility in the next 2 years for us to be talking about the PPP model, which government is talking about, because we are in a position to deliver it, whereas many of the government hospitals may not be at this point of time. And lastly, we have to understand that many of the clients don't come to us for syndromes. We create syndromes. They come to us for symptoms, or they come to us for subclinical syndromes. And we have to see what is priority, what I can deliver, whether the person is in a position to understand or not. Because unfortunately, many of the therapists are able to advertise. Us, we are not able to. And thus our work is what will be speaking for ourselves. And that's something we will have to prove in the coming years.
Thank you, sir. Thank you for the enlightenment. But thanks to COVID, that it has really had created a platform for us, a digital platform where India had seen the development in the technology very fast, which is supposed to happen 10 years, or it's supposed to take 10 to 15 years more. So next question is Dr. Avinash D'Souza. Sir, telepsychiatry includes audio-based, video-based, and text-based interfaces to provide the psychiatric services. So throw some light on how to choose an appropriate interface to provide the psychotherapy or counseling in the context of what type of consultation, first or a review consultation, or a diagnosis of the patient, or the type of therapy which is being provided. This question is for Dr. Avinash D'Souza.
Okay. Well, I think, see, one of the most important things with any digital platform usage is that both the patient receiving therapy and the therapist have to be very comfortable on that platform, meaning they must have used it many times before and probably have been regularly either using it as a medium to call family and friends, and they are comfortable to speak on it. Also, I think from a therapist's point of view, uh, um, there are multiple platforms available. So in the sense, you may use just a plain simple WhatsApp video call or a Skype call, or you may use a Zoom meeting or a Google Meet link, or for that matter, a WebEx link. You may also be a part of certain online psychotherapy platforms wherein you use their software to sort of speak. But finally, what matters is how the patient and therapist are placed. So the therapist has to look at his alignment, look at where he's sitting, how he's sitting, how he's going to speak, and the background that he's showing. So that's something which is very, very important. So, you can't really, it has to be a more clinic-like setting. It has to be appropriate that way. The patient has to feel he's talking to a therapist. Similarly, you have to have the patient also appropriately dressed and appropriately sitting. It can't be that the patient is in a kitchen, cooking and talking to you. So those things are something which is which have to be pre-decided. And I think very, very importantly, your internet connection has to be strong, because I think that's one of the major flaws we face when it comes to telepsychotherapy sessions, because you suddenly go mute, you suddenly go blank, you suddenly lose connectivity, and the whole essence of the session is lost. I mean, imagine a patient telling you something very important about his personal life or a history of trauma or abuse, and suddenly you lose connection. The patient just loses the rhythm in which he's emotionally probably expressing to you. So your connectivity has to be seamless. Even audio, I mean, even a non-video platform works once you know the patient and once he's comfortable with you. When I'm seeing a patient for the first time, I always prefer to have a video consult so that I see the patient. Well, there are telepsychotherapy guidelines which have been made by NIMHANS. There have been telepsychiatry guidelines made by NIMHANS. But again, I would say we clinically have to probably mold and modify them to suit the kind of practice we have. And it's also very important that you have to give enough time. So you can't have distractions, noises, background noise. All those things are very important in the therapy setting. And I mean, I think that's something. I mean, I will give a very sweet example. I mean, if you look at Rao sir, I mean, if I went for therapy to him with the coconut trees in the background, I would feel, definitely nice. I would not feel bad at all. So I think, where you're sitting, how you're sitting, those things matter a lot. And, if probably they would want, and I think you have to be able to see the patient's face properly. There should be no blurring. Certain emotions should be visible. Even if a patient starts crying on a video call, you have to be able to see that and, probably tell him to have a drink of water or probably take a 2-minute break. Even if you're not able to do that, then I think the whole therapy purpose goes out of place. Thank you.
And about the diagnosis, how to choose do we choose all psychiatric patients, all diagnoses for the therapy, or we choose certain diagnoses?
Okay. Now, I again here will reiterate that I agree a lot with what Dr. Avdesh sir said, that patients don't come to us with diagnosis. They come to us with symptoms. So they'll very often say, "Mujhe chinta hai, mujhe dukh hai, mujhe ye hai," and they come to you for therapy with that. They very well then they expect and they come and tell you, "Sir, do I have a disorder?" That's very often their question after the first session. Now, the key thing here is that I think diagnosis-wise, obviously, if you have someone who's very much in acute psychosis and violent and not wanting to talk to you, there is no way you can probably do therapy with him. or if you have a patient who's going to just be aggressive, abusive, or is it, I mean, acutely suicidal, I wouldn't want to do an online session with him, because you don't want a situation where a patient tries to cut himself in front of you and then just switches off, and you really then you'll be running pillar to post to try and save a life at that point of time. So I think you speak to the people who are referring him, you speak to the patient, get a gist of his symptoms maybe on an audio call, and if you feel this warrants only a personal face-to-face consult, either refer him to somebody in his area, or if you can do it in your clinic, do it. On only then decide about, when you're very sure that okay, this is a non-dangerous kind of patient, then probably decide about psychotherapy.
And how about conducting behavioral therapies for OCD or any other diagnosis?
Yes. Now one of the things which I feel is there's a lot of augmenting material that has to go with your telepsychotherapy. So you have to have a lot of self-help worksheets, a lot of self-help material. So the patient has to have a lot of homework to do between therapy sessions. I think for OCD, I mean, you can discuss the behavioral therapy model that you want to follow, whether it's flooding, whether it is any kind of exposure and response prevention. I mean, but what's important is all that has to be given written with instructions to the patient. Maybe you email it to him and he has to go through it, get back to you with queries, be very clear about what the therapy is. You also have to have one family member who takes charge that this therapy will be in place. And you probably would need even 15-minute follow-ups every 2 days, to see and assess the situation. And I think then only your behavior therapy would work through a telepsychotherapy mode.
Correct. Thank you, sir. Thank you for taking these questions. The next question is for Dr. Anukant Mittalji. How to take care of the important aspects such as consent, security issues, confidentiality measures, and ethical aspects to conduct psychotherapy and counseling using technology without any hazards. Sir, you're mute.
Okay. First and foremost, you said about consent.
Yes.
My way of circumventing any paperwork or any this thing is to learn from some of my seniors. Is that when the first contact is made, I advise them to contact me on a medium where we will be doing further consultation, and they have to initiate the talk. And normally it is like to fix up an appointment, they would call me on WhatsApp or something which is encrypted and which is a record that can be maintained and retrieved later, in which we discuss the therapy that we are going to do, the goals that we have, the objectives of our sessions. And at times with certain patients, I also discuss the amount of fees, which is on the WhatsApp chat. So it is a matter of record that they have sought help and the terms and conditions of the help. So that kind of for me works as a consent. I don't know, Dr. Pramod, who called me, I suppose, and Dr. Avdesh as opening batsman of experience, but he is much more experienced in online and off face-to-face therapy than we have. He will probably be able to give you a better advice on the consent part of it. As regards confidentiality and ethics, use platforms which are end-to-end encrypted. The usual rules of therapy apply. I have been trying to shout aloud numerous times that there is no sensible reason. Why do we call it virtual? It is not virtual. It is real. The only thing is the medium, it is online. It's not face-to-face. It is not virtual. It is not imaginary reality. It's a reality that you're having a conversation with a family, an evaluation with a patient. You're discussing the issues, you're discussing therapies, you're discussing even drugs, you're discussing even medications. You're discussing all that in real time, not face-to-face, but offline, off real time. It's being done on the web, or it's online or on telephone. So why do we call it virtual? There is no virtuality about it. It is a reality. It's something that is actually happening. So the confidentiality aspect, I think, is taken care of by the encryption of the media that you are using. There were some issues about Zoom, which is one of the most convenient forms to use, or the WhatsApp group calls, whatever, video calls. They are end-to-end encrypted, and the confidentiality is maintained. You are able to record, if you wish to, the whole session, which is excellent, and keep it for your records. That, I think, fourth question you asked was ethicality.
Yes.
Yeah, ethicality. The ethical issues come here is, of course, let me go back again to confidentiality. The usual clauses do apply. When the patient starts expressing certain ideas of self-harm, helpless, worthless, hopelessness, or signs of suicidality or intentions, you have to actually record that aspect of the session where you inform the patient that at any certain given point of time, if you fear there is a risk of harm to the patient by themselves or whatever, you will need to have the liberty to take a call, and with the patient's permission, you would contact somebody responsible who would take care of the patient's safety. And this is something that you need to discuss and keep a record of it. Right, so that is where your confidentiality breach exceptions are mentioned and recorded with the patient, and these are the terms, non-negotiable terms that you set with the patient, either at the beginning or in the midterm when you feel the need to. These are non-negotiable, right?
Right.
As regards ethics, in the current scenario, it is unethical for me not to provide listening ear to a patient who has been following up with me for his bipolar or a depressive or a whatever obsessive compulsive symptoms for a long period of time and has been spending sessions with me. And since now I am not able to meet the patient face to face, the patient, the care expected to do. See any ethical issues online, and especially now that we do have the.
So your voice is breaking. We are unable to hear you.
Okay, now?
Yeah, now it's better.
Yeah, okay, sorry. So we have guidelines from the Medical Council, we have guidelines from NIMHANS, we have guidelines from IPS, and soon I think we will be having guidelines from IAPP, which will govern, which will kind of validate our, justifying the use of non-face-to-face time to do therapy with a patient. Did I miss out any of your points, Shweta?
Nothing, sir. Nothing. You've answered all.
Yeah, so I'm DNP passable?
Yes.
Right, okay. Yeah.
Okay.
Right.
So then next question is for Dr. Parma Kumar, sir. What are the legal aspects that we need to know to provide psychotherapy using an online platform? And special focus that I would request is cross-border psychotherapy outside jurisdiction of India. Are we allowed to do that?
Okay. Okay, Shweta, and just confirm I'm audible to you?
Yes, sir.
Okay. Now, first of all, telepsychiatry, telemedicine guidelines, it's very important to understand these are not simple clinical guidelines. It is not a simple guideline which we find from other organizations or other kind of professional bodies. No, this is an act. All the guidelines which has come from telemedicine guidelines, which are supported by telepsychiatry guidelines, they are all by the act, basically. because the moment it has become an act, you don't have a choice, you have to follow it. And if you look at the modalities, we all do different kind of treatments and different platforms which we use. For example, I'm not comfortable with ECT. Nobody can force me to do an ECT. If I find a person who need an ECT, I'll refer him. Similarly, that like Dr. Avdesh is saying, and other people are also saying, telepsychiatry is not something which is to be followed by each and every. I've just written an article, an invited article with my friends from UK. There I mentioned it very clearly that aspect in India, people have been doing telepsychiatry, telemedicine consultation from the very beginning. For years, the moment you advise anybody out of your office chamber on a telephone, it is a telemedicine. It's a teleconsultation. Only thing what has come now is a model. It's a kind of a structure which has come, and we have to move within that structure. So if you are not comfortable with telepsychiatry in any way, whether it is a patient, whether it is a diagnosis, or whether it's a problem or a platform or a finance or a legal issue, you should not be doing that. Telepsychiatry. That's my standard advice to everybody. Number second, people believe, and they have always believed, it is something which is very casual, that you can talk to the patient at any time, or patient can approach you at any time, and they can discuss anything, whatever they wish to. It is not like that. I know I have been practicing telepsychiatry for more than 2 decades in different formats. And the first thing when this guideline came, it really brought in a lot of happiness to me. Because now I know what we have been doing. Dr. Prasad and me have discussed this for the last 3-4 years. Rather, our international travel were all focused on telemedicine, how we should be doing, how we should be doing. So now there are guidelines. So we know we have to follow it. Number third, it brings in lot of responsibility and liability. Responsibility we all understand. Rather, we are more responsible than being a doctor itself. We think about the patient first. Patient never mentioned this is expensive. Patient never mentioned this is internet problem. Patient never mentioned that this is something which I don't think I should be talking to you, or this is something for poor people, for rich people, or for others. We are the one who think a lot beyond our capacities, beyond our responsibilities, and that is something which has brought in a problem. Look at the recent case of Dr. Tarun from this Ria Sushant Singh Rajput. This doctor would have not done anything out of bad intention. Is simply a person who had advised like many of us would advise, okay, without knowing the consequences, and it land up in trouble. Today, this is the first case which has been registered under telemedicine guidelines. So it brings in a lot of responsibilities and a lot of liabilities as well. Those liabilities are much more because today you don't have patients who are coming and visiting your clinic from a very limited geographical area. Like in my clinic, I do see patients coming from 5-6 states. Delhi people see from lot of states. Yesterday, I had seen a patient from Jharkhand, from Mumbai on telemedicine. So now the geographical boundaries are blurred. Even international boundaries are blurred. Okay. People can approach you at any point of time. So you have to understand the magnitude of liability as well. Today, a case get registered against you in Mumbai, in Tamil Nadu, or in anything. You are the one who have to take care of your all the. So that means your insurance coverage, your responsibility. You have to be very, very serious. You should know exactly what you should be delivering and what you should not be delivering. Then comes the cross border, which you have just mentioned. See, it is very clearly mentioned the jurisdiction of telemedicine guidelines is India, pan-India. In 2018 only, the Medical Council of India has amended in their etiquettes that anybody who's registered under Medical Council of India can practice telemedicine. This came 2 years earlier. and you don't have to have a separate registration, which is required in many countries like USA. You have a telemedicine for a particular state only. Over India, our jurisdiction is India. I have patients who are coming from so many countries. There are people. You have to mention from the very beginning the jurisdiction of telepsychiatry is India, and preferably you should do counseling sessions. Counseling sessions you can do even in American Psychiatric Association guidelines. You can deliver only counseling session to anybody in any part of the world, but your jurisdiction will be in, like you are giving counseling to somebody is a patient in Australia. He cannot register a case against you in Australia, okay, because your jurisdiction is India only. The degree. As far as counseling is concerned, you can go. As far as pharmacology is concerned, it's a best and safest practice is to do treatment only for those patients who are in India, or those patients whom you have actually treated physically in India, whom you have, as per the guidelines, you have seen them, you have treated them, you have taken care of the initial symptoms. Now you're doing only the follow-up consultation, which you can do as per the guidelines. So it requires a lot of liabilities as well as. So if does that answer your queries?
Yes.
Can I add something to Dr. Pramod's
yes,
last?
sir. Yes, sir.
Yes.
Yes, there are as far as pharmacotherapy goes, if you are licensed to practice in the country where the patient is from,
yes,
then you're allowed. I have a permanent registration of UK and the European Council. So I can prescribe for European and UK patients now that UK is out of Europe. I can prescribe from them because I have a permanent registration with the General Medical Council and the European Council. So as long as you are allowed to prescribe in that country,
correct,
you are allowed to use the prescription. Yeah.
Yeah, absolutely. What he's mentioning that because you are a license holder of that country and you can prescribe in that country. At the same time, if you because when you are given the license, your nature, the kind of practice, the place of practice is also important.
Right.
Let us say if I have a license for Afghanistan and I'm sitting in India and seeing all the patients, okay, so my jurisdiction of practice as of now is India. When sir can go to England, he has a locum practice in England, he is allowed to practice in England. But sitting over here, he will not, the privilege of being UK license will not hold in India. This is what my understanding is. However, there are patients, I may be having more than 500-600 patients whom I have treated. I do a prescription, I have done a prescription for them. I always write as a safe practice, when they are under follow-up, please consult your local psychiatrist or a GP for continuation of treatment. Okay. And for emergency, consult the emergency services. I always write that kind of a prescription. 5-6 times my prescription, when the people in US, when I mention about my American international fellowship and ambassador status, lot of time the prescription which I have given to my patients in India, they are very much honored by the GP in US. They're very much honored in Canada as well. The prescription which you give to your patients, but you have to mention very clearly since how long you are seeing these patients and what is the nature of treatment which you are giving to those patients. But it is, you must know the liabilities associated as well. This is important.
Okay. Have you faced any legal issues while treating your patients on a telepsychiatry platform until now?
Luckily till now, none. I have one patient. I have one patient whom I have stopped the therapy. Only in one patient till now, and that was because this is a lady. She's a cop from Canada, and she was under my therapy session. And so in the beginning itself, this has happened about 2 years back. So in the beginning itself, I set in this is called a telepsychiatry or a counseling online etiquettes. So there is a list of etiquettes which are mentioned, the time, the consultation, the dressing, and all that. So once this patient came to, she called me up from Canada, and that's our morning and their evening time, and this lady came back she was calling up from a pub, and it was a video consultation, and she was holding a glass of wine in her hand and says, "Okay, doc, I was to have a talk with you." So I just looked at her, and she was not dressed appropriately. I says, I told her, whatever her name was, you are in a nice mood right now, but this is not a time, or this is not the therapy setting for me. And I think we need to, and that was a planned session. That was not something which was a unplanned. That was a planned session. That I told her very clearly that this is not something which I would appreciate for having. You better enjoy your evening, have fun with your friends, and whenever you have you can refix, and we will. I'm not going to charge for this particular session, and you will fix it up again. So after another 1 week, this session got aborted. Another 1 week, she came back, and she was at home at the right appropriate timing, and she was topless at that time. And I say, see, this is something which we have discussed. And this is a session, not a new session. I must have had about 30 sessions before that. And we have checked on the transference and counter transference, all that aspects at the same time. I told her that this is something which is really inappropriate. And this we had discussed in the beginning itself. I don't think our therapy, the etiquettes of therapy are being followed. So I strongly recommend you take your time, take a cool off time. You think over, go through the etiquettes, whether you would like to continue with the therapy, or you should better change a therapist, because the discomfort in therapy is something which should not be there. Okay, so that is one case in which I voluntarily aborted the session. After that, there was no communication from her end also, and I also did not pursue the communication and close that session. So you should know that. There is another patient who complained to me. She's under my therapy right now. And she complained that another psychiatrist who was treating her was masturbating. I'm telling you, while conducting a session. She complained and she asked me what should be done. Okay, now these are so like Dr. Videsh mentioned in the beginning itself, we are not, in therapy especially, we are not handling diagnosis, syndromes. I always call it as a problem. I don't even call it as a symptom, because symptoms are a part of diagnosis only. I call it as a problem. We are the problem solving therapist in counseling. And there are many problems, rather more than 90% of the problems are out of the textbook. Okay, so you have to know all these things, because this is something, otherwise these are the cases which I've just told you. Tomorrow, if I conduct a session and it get recorded, look at the liability. Tomorrow she can say the therapist never mentioned anything and he was getting an erotic pleasure out of my discussion, and this is something, he has a more responsibility for the therapy. So we should know exact boundaries of therapies. So etiquettes are very important to understand.
Correct. Thank you, sir. Thank you for sharing your experience.
Yes.
Sir, the next question is for Avdesh Sharma, Dr. Avdesh Sharma. How can we improve the quality of this interface, knowing about the legal issues and the ethical issues and the etiquettes? How can we improve the quality of this interface without diluting its purpose? Dr. Sharma ji?
All right.
Yes.
So 2-3 things have come out. This is a part of the whole thing. I was using the etiquettes so that my sound doesn't leak in, but I have to be careful to put it on at some point of time. So the same thing in therapy, like Dr. Pramod mentioned, I think the online therapy is much more strenuous than physical therapy, because when you are going there, you're going there with a purpose and you are in that mood. Transference, counter transference, non-verbal cues, all that is something we are trained for. Here, the training is happening on the job. That's one part. Second thing is that, you have to be very careful in what you are treating. Because sometimes the many sessions will start meandering, go from here to there. And right in the beginning, we have to be careful, what am I treating, how many sessions? And at some point of time, maybe after second or third session, I would start saying, am I going in the right direction? Is something getting here, there? Is the person distracted by other things? Now, as far as the basic issues of what and how to go about the whole thing, first, we should be comfortable, like Rajesh was saying, about what I am comfortable in treating. And if I'm not able to, I think this is the best platform where you say, I don't think I'm able to help you. For example, there are many clients who would come and say, I have addictions and I want you to help me. I've heard about you, etc., etc. And I'll tell them, I'm not comfortable in dealing with addiction and I'm not comfortable in dealing with it on this particular platform. Second thing is that, there are lots of people at this point of time who are offering therapy. And if you were looking at from a global health perspective, we need other therapists, but we cannot forget the guidelines. They have to be RCI certified. So if I am teaming up with somebody, if I'm having a consortium of people, because at some point of time in future, I think the group practice, especially from these platforms, Anukant, I wouldn't even call it virtual platform. You have raised a very good point. But yes, platforms which are definitely using technology, then we would be able to start offering services. Like if you have a problem with cancer today, you can go and get it done from John Hopkins, get a second opinion, maybe start getting some kind of a therapy before you have reached it. So India today would in future be able to offer these services. And I think that's what we need to be gearing up. But all of us have to become comfortable in the zones, in the kind of things I'm able to treat, the kind of people I can connect with, similar minded, same ethics, same kind of background, language, etc., etc. And then once we are able to do that, I also will propose something in this art of psychiatry, that today it is no longer probably one-on-one therapy. There are models of group therapy which can be very easily applied. And I think that's where the future lies, especially for, let's say, mild symptoms. If there are 10 people who are having insomnia, nothing stops me from having 2 group therapy sessions. They could probably switch their video off if this is a question of confidentiality. And then one can have one-on-one sessions. It's much more easy now than when we used to have group therapy of people coming and being at one physical place. So those are the things today which are becoming a possibility for us. And many of us who are not so busy, this is the best time to get trained. This is the best time to give training to younger colleagues whom we couldn't give earlier because there were physical issues or whatever. And I would even suggest that IAPP could start a course or training workshop modules which can be taken up in future because this will not be probably happening from big institutes, but for the practitioner, this is something that we can do. And keeping all the guidelines, keeping all the things, I think we will be able to serve many more people, especially if we team up with other mental health professionals, therapists who are trained, who are certified. And if we can do it in groups, then we can start looking at much larger number of people whom we can serve. And especially after probably 6 months to 1 year, there would be many more syndrome related to corona in terms of mental health, which would be coming up, which are not there at this point of time and which none of us are trained for. And that's something that we need to start looking at.
Okay.
Shweta, looking at just symptoms but not diagnosis. Is it not difficult to conduct, sir? Like, for example, we have diagnosis of major depressive disorder, and I have a group of people with major depressive disorder. So I deal with them collaboratively all together. So, I mean, the negative cognitions, the cognitive errors can be dealt according to the diagnosis. We have named psychotherapies like CBT for OCD, CBT for depression, DBT for borderline personality disorder. So, what I meant to say is diagnosis not important?
Diagnosis is important for pharmacological interventions. After that, it could be me, who's also giving non-pharmacological interventions if I'm trained in it. Or I could have another colleague who looks after that, but we have a working liaison with each other so that we are able to give a feedback about that. Because at the end of the day, the person who's coming for psychotherapeutic process is doing that for symptoms, is doing that for distress. If there are other clinical symptoms, then obviously they will have to be handled with pharmacotherapy. I would go even one step further, and some of the work that we are doing now with the WPS section on spirituality and mental health is to train those who are on the ground. And we are training now professionals, call them professionals who are spiritual therapists. A lot of people who may have interest in mental health, and they have large clients. They have clients in thousands and lakhs, and many of them are suffering from mental health issues. And they are also willing to get them treated, but they are looking for mental health professionals who are able to work collaboratively and not say that, this is not your department or whatever. We keep saying it's not your department, but how am I going to handle 18 crore people according to Niman survey who was there in the country? So I think somewhere we'll have to go for global mental health, and especially those people who can be handled in terms of less number of symptoms with other psychotherapeutic modalities, may not be handled by professionals.
Right, sir. So I move on to the next question, sir, for Dr. Avinash D'Souza. Performing self-assessment scales on an online platform. Can we do it in the real time during the session? Is there an easier way where the patient can type in their responses for the self-assessment scales while I'm doing the therapy?
Well, I think it's possible. See, there are two ways to do this. One is that maybe you do it prior to your session and have the patient share the screen and show you his responses, and you discuss it probably if you want. The second way is that you share a screen, go over the scale with the patient, and he reads it and he tells you what score to put, and you put, and then that gives you an idea. That's another way out. And a third way out is that these could be part of the homework, which is given to the patient. So this is how I think it is done. It is really possible in real time, definitely. And I think you can even have a method whereby by feeding in his scores, you can graphically show him on a Word document or a PowerPoint, what symptoms are higher and what symptoms are lower, and use virtual technology, to the maximum.
Anything as simple as a Google Doc?
Well, definitely. I mean, I think it's see, particularly we do have Google Docs when you give him homework exercises. We have Google Docs even for rating scales, wherein he shares, his viewpoints. You add, you can get back to him, and there's a constant sharing. See, in fact, initially when the psychotherapy happened and there was no online platform, like a telepsychotherapy platform, we have done email psychotherapy also at one point of time, wherein we had specific write-ups for specific symptoms, which we used to mail the patient and have an email chat going on. So definitely a Google Doc could be used.
The confidentiality will be maintained in a Google Doc?
See, as long as only both of you all have access to it. Now you're giving access only to the patient and you're giving access to yourself. Now, if the patient then gives access to someone else, that is not something which is in your control.
Okay.
Dr.
Parmod sir, would you like to add something?
Yes. This is what I do in my routine clinic. So I have something called a remote testing facility is a part of my clinical practice. So remote testing is basically, I bought this. These tests are paid tests. I've done it through the San Francisco-based CNSVS model. So there is a huge list of neuropsychiatry, neuropsychological assessments. There are more than 60 tests which are there. Okay, they're all paid tests. Then there is Nova Psych professional version. So this is a inbuilt remote testing facility. If suppose I want to do a neurocognitive assessment, I want to do a memory function test, or a personality assessment. What I do, I have data of my patients. So this is done for all registered patients. So what I do on the registration, I go to my website, I generate a remote testing code. It's built. I fill in the detail. It tells me to whatever test you want for that patient. The moment I generate that code goes to the patient's email. And it comes on my screen with a reminder, with all instructions. And the person sees on their mail, because this is already being discussed with the patient. This is the test which I am planning with you. So he will check the mail. There is an instruction which will come up. This is a complete laptop, iPad-based assessment. They will complete the assessment. After the assessment is completed, it comes in the view report on my website, on my platform. Person is not able to see his own report himself. Okay, the report comes automatically. The moment he open a file, he asks him to pay for the test. So for example, 4,000, 10,000, whatever the cost, the moment he pays that, then the test gets started. And after I view the report, then comes the counseling session of the reporting part of it. This is called remote testing facility, which I do for all my patients, whatever, and they can do it in any part of the world.
So where can we access this, sir?
Who? The patient or myself?
No, the therapist. Obviously.
Therapist, because I have a complete platform with me, in which all the tests are there. Correct. All the patients' reports are there, which are being done in my clinic. All the psychologist, whatever test he is doing, it becomes a part of the lab. It comes in the laptop, in that software. Once the person does a test in fact, it tells me, your patient has opened the test. Your patient has closed the test. Your patient has taken 35 minutes and 20 seconds to complete. He has made this payment. The report is already uploaded on your platform. You can view the report and discuss. You can then reminders goes to the patient. Okay. This is all part of my inbuilt online sessions, online systems, which is there with me. It's a wonderful program.
Oh.
I designed it.
You designed it by yourself?
Yes, this whole website is designed. This all is an integral part of my own designing. Only I had an IT professional who knows the coding system. I do not know the coding systems, but each and everything which I told him, he has done that.
That's great. That's great, sir.
And it's quite a pain. It pays a lot also. This is something which is important to understand.
Correct. Yes. So the next question is for you, of course. What are the practical difficulties or challenges that you faced using this interface, and how did you handle it? Especially the emergency issues, like a suicidal patient, or suicidal ideations, or any attempt, or suppose you've been dealing with MDD, patient with MDD, and then suddenly he turns out to be manic, and he's in a remote area where he can't access your place. So how did you deal with such kind of emergencies, and especially when this is in cross-border?
Okay. Now, first of all, whenever anybody approach me, he approached me in a state of distress. The first thing is to listen to him carefully. Listen to him carefully is important. Not that he says, I want to commit suicide and this and that, and it's straight away rejecting. No, I cannot treat you. My dad has got a delirium. I said, I cannot help you. No, I do not do that as a philosophy. The first job of mine is to provide him immediate relief in terms of listening to the person, understanding the basic problem, what the person is having, and then guiding him appropriately. Okay, that these are the kind of issues, let us say manic excitement, or a florid psychotic patient with a lot of delusions, hallucinations, delirium patients. I know I cannot help him at that moment of time. It requires a psychiatric emergency treatment, it requires a medical emergency treatment, but I do not outrightly reject them. Listen to them, help them, tell them to where to go, rather help them. I help them. Yeah, 3-4 days back, one of my patient is in US. He's a young child. He has got a panic attack, and then I was treating him on a counseling. He was undergoing this remote testing. Also, I have done on him. Now it tells me 4 days back. I was wondering why he has this. Now there is a history of marijuana which he did not discuss earlier with me. So he says, I've got a marijuana which I generally used to smoke about one cigarette a day. Yesterday I consumed 4 cigarettes, and that is what precipitated a panic attack in him. And he definitely needed emergency treatment at that moment of time. So I guided him, go to emergency, and this is how you are going to be helped. But listening to the person is extremely important. And if you go in the literature, there are strict criteria whom you should be handling and whom you should be referring and whom you should not be touching at all. Like the people who are risky, threatening, I'm telling you, today people are not understanding. You will find much more litigations coming up only for teleconsultations as compared to what has actually happened in a physical consultations. This is an area advocates are going to utilize this area for finding out faults. So be very sure on that.
Let me just add one thing here. Pramod,
Yes,
what you said just now. Today I don't know who is recording a session which I am having with the client. There could be another person who may be handling that, recording it, and maybe tomorrow misusing it. Or the patient tomorrow says that, this is what you said, but this is what I thought you said. That is enough for his lawyer to, start the initiation. So we have to be extremely careful in what we are saying on these platforms rather than what we were doing earlier.
Absolutely.
Avdesh and Pramod, this would happen 15 years ago when people had mobile phones which had recording facility in that. I don't think there is any risk change just because they are remote and not you can't see what they're doing. There could be a patient sitting in your clinic who's got his phone kept upside down on your table, which is actively recording everything, including a video. Right. So I don't think that is any substantial change in the terms of security risk of what you're saying. And as long as you have said something and your interpretation and his interpretation, the fact that he has a problem in his cognition, his understanding was different. How you can obviate is probably ask the patient to repeat what he's understood of what you have said.
You're very right, Anuka.
That is very often what I do. That if I have a patient who has in the shown signs of misinterpreting or twisting words or manipulating your words or your intentions, I have asked them to repeat what I have said and what they have understood from it.
Yeah,
it's as simple as that.
I just flagged it for one simple reason, that when we are doing therapy remotely, we tend to become a little lax, and that should not happen.
This is exactly
that's one point.
Exactly, yes, sir.
And the second is that of course, even earlier on, we had no way of checking up if somebody was to turn up, say, I'm so and so, like what Pramod said about that thing about Sushant and prescription, etc. Today, somebody can very easily say, I'm so and so calling. You just have a phone number of that person. So one has to become extremely careful in what we are prescribing and what we are saying, and
which is why
if necessary, then maybe just a screenshot.
Which is why I say that I have. I'm sorry, I don't have that many patients, so I can probably say that. But I save each patient that I have seen or who has contacted me, whose identity has been physically seen by me or whatever way. I save their phone numbers. And if they call from a number that is not known to me, I ask them to call from a number which has been saved by me. That is one. And of course, as I said, for consent or whatever, I make them send me a WhatsApp. If they have any problems, if they are talking about issues that can be contentious in future, I ask them, can we do one thing? Could you be more explicit by sending me a text message on WhatsApp?
Yeah, that's wonderful, sir. Thank you for all your responses. Yes, sir.
I'll
please.
make a last. I'll just make a last comment.
Sure.
From all the years of my practice, I always believed that the patient will record or may record.
Yes.
And whenever they ask me, I've never asked till date any patient not to record.
Yeah.
Not to record. I've never asked anybody. They say, sir, I want to record, please. And I believe even if you're doing a video consultation, this is exactly, you have to be very careful in choosing words. I still remember 2017 with Dr. Prasad Rao in Australia, and we were discussing about how the sessions are conducted, and we are on the top floor of a hotel. I told him, why are we worried? Because many of us talk very casual.
Yeah.
We talk very casual to the patients. We go beyond our boundaries. We address them differently. We become friend. And this is where the problems are going to be. Till now, there were no guidelines. So till there were no guidelines, so no rule, no act, no punishment. It was okay. Now there is act, there is a punishment. So today you have to be very careful what you talk. I have never done teleconsultation to any patient out of my chamber. I don't do strictly. Yesterday, patient called me, sir, I want to have a session today. Saturday evening, I don't do my OPD. Sir, online ही तो बात करनी है. मैंने कहा आपके लिए online है, मेरे लिए वो proper consultation होती है. You first have to register in my clinic. There is a registration program. Then there's a OTP authentication. For if you don't have, I'll tell you, there is a very simple system by a OTP authentication software, which is very, very cheap. It is just few seconds per call. The moment a person registers in your clinic, OTP will be sent, like bank and other people are sending us OTP. This is a authentication. So there is a program run by the Telecom Authority of India. It authenticated, get recorded that this is the person, this is the identity, and it immediately get clicked onto his IDs. So have that program, you know the identity of the person whom you're talking. So don't be afraid. This is an opportunity for us to have telemedicine and utilize this opportunity thoroughly, but within the norms. This is my understanding.
Thank you, sir. I should personally thank all the 4 panelists for their wonderful inputs, and I am really benefited. I am personally benefited with this panel discussion, and thank you, IAPP, for giving me this opportunity.
Thank you, Sweta, on behalf of IAPP. I would say, apart from you, 300 plus psychiatrists are also benefited by the way you ask the questions and by the learned speakers. Avadesh especially and Pramod, all 4 of them from their deep digging out from their experience gave real pearls of wisdom, and I thank all 4 of them. Now this is all for Pramod. I would request Pramod. Pramod will take over for the valedictory. Brief valedictory, I won't take more than 2 minutes. I would request Pramod to conduct that, please.
Thank you, sir. Thank you.
Thanks. Yeah.
Yes, sir. Thank you. And it's my privilege as a honorary general secretary to conduct the valedictory program. So I wish to first of all thanks Dr. G. Prasad Rao, the president, who along with me, he in fact asked me that we should be conducting this academic program of IAPP irrespective of the situation. And we have successfully conducted the second program today. Third is going to be next, and then is going to be NCF. And it's with his energy, wisdom. I'm really thankful, and the program have gone extremely well. I also wish to put on record thanks to Dr. Afzal Javed and Dr. Helen. You know, they are the big shots, I would say, in the world psychiatry. And for our program, having them, again, I wish to thank Dr. G. Prasad Rao to have them spend time, talk to us, and bless us. And their definitely presence makes us the importance of IAPP to international people. That's it. I wish to thank Dr. Avadesh Sharma and Shweta, both of them, because I know Dr. Avdesh Sharma was not well in between, and he had a little resistance whether he will be able to attend the program or not. And I think this program was entirely Art of Psychiatry program. It's entirely your program, and we are just the support for that program. I'm extremely thankful to both of you and for the successful conduct of this program. I wish to thank all the faculty members and my office peer who have given me constant encouragement and energy to carry on the activities of IAPP. There are more than 300 people who have attended this program, and I think attending Sunday evening program is not something which we are very much fond of. In fact, our all conferences would end by Sunday afternoon. So it is not registered, it's not conditioned in our brain to see something, to hear something in the evening of Sunday. So having 300 people, that is an extremely good response. We people have worked hard for this program. All the office, then I wish to thank all the chairpersons who have conducted the program, conducted the sessions very well. And I also put on record thanks to Sunpharma for giving us this kind of an educational grant and time and opportunity and logistic supports for conducting this program. Although this program had to happen because this is with a heavy heart, we are still missing. We have not come out of that emotional feeling which we had with Dr. Amar Chawar, and our deepest condolences to Jhamar family, and we have talked to them and conveyed our message personally. So thank you very much, and enjoy rest of the evening with your family and friends. I don't know how you have friends, so at this moment of time, definitely with family. Good evening and good night to all of you.
Good night, good night, good night.
And thanks to Ramakrishna and Srinivas for being the kind of back end support for us all the time. Thank you very much.
Thank you, sir. Thank you all. Thank you very much
for involving us, sir. Thanks a lot, sir.
Good night, and Avdesh, you are always with me. I told you will come. You have come.
I must say one thing.
Yes, sir.
I have, because of my indisposition last 2-3 weeks, they have been very kind, both Prasad and Pramod, and of course Dr. Shweta. I have really not contributed the way I've been made to feel.
Your presence is a contribution. That's sufficient for me.
Yes.
And you did contribute. I talked to you about the speakers and you said yes.
Yeah, sure. Thank you.
Sure.
Thank you.
Thank you.
Thank you, sir. Have a good night.
It's a very nice program. Congratulations and good night.
Thank you, madam.
Shweta,
Good
thank
night.
you.
Good night.
Shweta, thank you very much.
Thank you, sir. Your blessings.
Yes.
Okay.
Congratulations, Dr. Shweta. You did very well.
Thank you, ma'am. Thank you. Hearing
I
from
think now you can
is...
be a DNB examiner.
Yes. That's nice.
That's great. So we will meet next month, 18th of October. We are going to have a child psychiatry annual
Child psychiatry program is shaping. I expect every one of us to be here. Thank you very much.
18th October date is finalized. Okay.
Date
Bye-bye.
is finalized.
Bye. Okay, bye.